Good afternoon, everyone, and welcome back from your lunch breaks. I hope you're all well fed and watered. We have managed to get the video from Professor Thacker working, and he was due to speak to us on the role of pediatric societies in achieving SDGs. So we will show this video now, and then we will continue with the next plenary session.
Hello, everyone. Good afternoon. I'm sorry I could not join live because of PMNCS board meeting happening at the same time. But I'm very happy to send my thoughts, and let me share my slides. Let's make it slides. So, okay. So my topic today is role of pediatric society in achieving SDG. You all know very well about SDGs, so I will just focus and try to be as brief as possible about what role pediatric societies can play in achieving SDG. So this is outline. I would like to start with some history of IPA, International Pediatric Association, and how pediatricians can act as change makers, and finally a call to action. So International Pediatric Association is 114 years old organization, and there are 3 history books on history of International Pediatric Association. But as I always say, history of IPA is history of pediatric profession. As IPA developed and had members across the world, pediatrics also developed. And this was because of some great men or leaders who had that vision, who thought about that if we need to develop pediatrics, we have to all come together. This is the first small group, and interestingly, as you can see, this was started in France, in Europe, in Paris, where first conference was held, and this is Victor Henry Houtinel, who was the president of first International Pediatric Congress in Paris in 1912, and these were his opening words, first words, that it was a dream come true for all pediatricians, and first time coming together in one platform, and that was the first Congress. So as he said that everyone is having from different countries different idea. Maybe many of them are doing research, but this is the place where everyone can come together and giving a chance through initially these IPA congresses where people can share their research. And this was going on for 20 years. Previously, we were very much part of OBG and some isolated groups, but not as a pediatrics as a profession. So, as he said, many of us were working in different area. So this is the common group where everyone comes together, and it should, as he said, it should resemble a tree with diverging branches. Some of them are sturdy, others are more frail. Some carry beautiful fruits, others don't, and there are not two the same. They all, however, return to the sap, to main trunk that holds them together and keep them alive. So this is the beauty of IPA, that even after 114 years, there is only one organization, international organization, where all pediatric society are under one umbrella. There is no parallel organization. We have 175 members from more than 160 countries, all subspecialty, all bigger society like RCPCH, AAP, Indian Academy. They are all happy to work under one umbrella of IPA. And he had just again given more guideline that how we everyone can work together and help each other, and that is how, as I say, the profession of pediatrics could reach to every corner of the world. These were his closing words. We wanted to go the pediatrician all countries where national society could be founded if they didn't already exist, and we wanted to connect between all these societies so they can unite in a common effort. See the vision, and still after 114 years, we do not have pediatric society in every small country, but we have in most of the places regional society, national society, and many of the subspecialty societies. This is the logo of IPA, Embrace logo, where if you see, this is, we can say this is IPA, these are regional society, and these are national society, or we can say this is the grandfather, father, and child, or anyway, mother and child. So, and our tagline is every child, every age, everywhere. And we want to reach every place. And how do we do that? We work with pediatric society, and those pediatric societies work with the pediatrician, and then pediatrician deal with children. So if we want to reach the children, we have to go through pediatric society, and we have to reach to pediatrician who are our ambassadors. This is another very interesting from the minutes of an interview in video, where Professor Ihsan Dogramachi, the president of IPA and then executive director for a long time, where Dr. Bahaluddin is interviewing him, and what he said is still today relevant. This was from a very old video. He said, put peace as a primary goal. Pediatrician and IPA should exert their advocacy and try to defend child rights. They have ability to do so because they are admitted to all homes and meet decision maker. And that is true. As pediatrician, we have access to every house, politician, lawmakers, everyone. And we have to, last thing he said, we have to listen to the younger generation and broad-minded enough to listen to their comments and criticism. So these are our forefathers of pediatrics. IPA has from 114 years old history has gone through many phases. First was organizing only conferences where pediatricians meets and share their research and their knowledge. Then 74 to 2000, IPA expanded and reached to every corner with regional society and reaching to the developing countries. Then in 2002, we had a first retreat where a lot of changes were suggested. And 2010 to 22, we have a lot of decentralization, engagement with the national society. And 23, we again had a retreat. And then we started on program area, constitutional amendment, and more focused engagement with the pediatric society. Because as I said, we can only reach to children through pediatrician and through pediatric society. So this is how strategic planning was done. And within IPA 2030, these are the strategic priorities which we decided after a very thorough prioritization exercise during that 2 days of retreat. You can see everything is important here. I'm not going into detail. Then we started forming the program area committee where we have 10 program areas. Practically all important aspects. These are the big committees where all the experts from different parts of the world, they work together. And then there are working groups, lot of interest group where small groups work, and sometimes they do more work than the program area committees. We have a very good webinar series, webinar module, and here you can see that we have practically implemented diversity, equity, inclusion, very clear instructions that it should not be a manual. Every webinar, every committee, every program area, working group should have at least 40 to 50 or even more representation of the women and from the different parts of the world. And definitely there is focus on the global south. Again, many webinars going on, largely attended and also viewed after the on our YouTube channel. We have many projects. This is one of the projects which we are working with American Cancer Society we have our own learning management system. I'm developing a course on HPV vaccine. Then we are doing a end-to-end process for RSV policy positioning with Sanofi. Then we have with WHO and UNICEF, World Bank, and International Food Policy Research Institute, we are doing a survey on the growth monitoring global survey, and so far 61 societies have responded. We hope to we will get response from 80 plus member society. This is another Gates funded project in two countries, Indonesia and Nigeria, where we are empowering pediatric association advocacy for immunization priorities. Large number of immunization champions are trained, and then not only at national level, but then also at the sub-national level where we do the regional workshop. And this is the first time that IPA, I can say, have every corner of Nigeria, every district level. We have our champions present. One nurse, one social media influencer, and one from the one pediatrician. So they are doing excellent job and very active. Now we just had an experience sharing workshop virtual, and then we will have in January a physical workshop. Same in the Indonesia, large number of again through the gates. We have changed a large number of people, and they are in every part of Indonesia. Another with GSK Global, we have this V2V vaccine to vaccination workshop, where last year we had 3 such workshop in Anglophone Africa, Francophone Africa, and South Asia. And this year, this was from the last year, and this year we will have 4, including 1 in Central Asia. Continue in 3 and have 4. We have our signature project, online vaccine trust course, which was very useful during the pandemic, and we have a very good publication how it was useful. 8,000 plus participants, and all the modules were completed by around 2,339 participants, and lot of testimonial on our website. So this is the convening power of IPA. If we really want to bring say pediatrician global expert, IPA can do within 24-48 hours. And this is we asked for the neonatal representative, and immediately we got from the 58 national neonatal representative. We Mpox, when Mpox outbreak was there, we quickly assembled a group, and they came out with our statement and guidelines across the world. Everybody contributing, and it was then published through our channels. This call to action was released in IPA Congress in India, Gandhinagar in 2023, but it's still relevant, where we have roped in more than 100 societies to support this, and this is still relevant. Finally, I would like to say that pediatric societies and pediatricians have a very important role in SDG, and they are willing, they are always ready, whatever job we assign them. And finally, I invite you all for a grand mela of great festival of academic and democracy in pediatrics, 31st IPA Congress, which will happen in Mexico City, 8 to 11 May, where more than 100 societies will join. And this is really a once-in-lifetime opportunity to meet our colleagues, fellow pediatricians from more than 100 countries. So please do join, please do register and join in the large number. Thank you so much. Abstract submission is also open, and you can definitely submit abstract. Please share with your colleagues. Thank you so much. I'm very happy to be always connected with you, and thanks for the opportunity to speak to you today. Thank you.
Fantastic. That was a really helpful video from Dr. Thacker. It's really key, isn't it, the work of working together, and part of the role of the child associations such as the Royal College of Paediatrics, the International Child Health Group, which is a small group of that, and then working closely together with bigger organisations such as the IPA. International Child Health Group, we also work alongside something called ISOP, which is an international group focusing on role of paediatrics and social kind of determinants of paediatrics, which we've seen all the way through today, is really, really key, because if the environment that the child is growing up in is limiting their ability to thrive, then it's a real difficulty. So I'm really pleased that we've been able to have that contribution from Dr. Thacker. As Helen's mentioned in the chat, if there are any questions for him, we would very happily forward them to him and get him to feedback. And our overall aim as the International Child Health Group is to work closely with organisations who are working in a similar space, working together to drive forward improvement for children and their health across the globe. So we are very pleased to have had him. We're about to start our next plenary session, which focuses more on the challenges of the Sustainable Development Goals. And we've heard lots of those already through various of our different speakers. We were due to start with Professor Uzge Karadag, but she's currently stuck in traffic. So I wondered whether, I spotted Sifa on the call, if it's possible for Sifa to join us first and join us on the stage and upload your slides. That would be fantastic. Sifa is a really good example of a really fantastic young lady who is doing her PhD. And she came to know about ICHG and get involved through one of the research awards. So Sifa is a global health researcher, a master's student at an Amsterdam university, which name I might not try to pronounce, but you can correct me, Sifa. And she has a passion to tackle global health challenges. And she's here to speak to us about some fantastic work she's been doing in Malawi, for which she used the Research Award grant to help with. She focused on infant hearing loss and did a mixed method evaluation, looking at the risk factors and parental perceptions of noise in the neonatal intensive care unit at a tertiary hospital in Blantyre, Malawi. And I imagine it's something that's very often overlooked, but has a big impact on children's development. So I'd really like to welcome her to the stage, and feel free to share your slides if you're able to. And yeah, welcome.
Yes, thank you. Can you all hear me?
Yes.
Okay, great. Then I'll share my screen. Okay, so I hope this is visible for you all. Can you see this?
Yes, it's perfect. Thank you.
Okay, great. So yeah, thanks for the lovely introduction. My name is Sifa Cunha, and I am currently a student at the Free University of Amsterdam. And today I have the honor to present to you the work that I did earlier this year. And I also had the great honor to receive the ICHG Research Award of 2024, which is part of the reason why I can be here today to speak to you all. So today I'm going to tell you a bit about the research project I did for my internship earlier this year, called Exploring Risk Factors and Parental Perceptions of Noise in a Neonatal Intensive Care Unit at a tertiary hospital in Blantyre, Malawi. So, a bit of background. So, hearing loss is a prevalent global health issue that affects an estimated 1.57 billion people worldwide. And at least 34 million children are affected by it, with 60% of all cases being due to preventable causes. And hearing loss can significantly impact children's language development, speech, and cognition, and therefore early detection and timely interventions are crucial to mitigate these consequences. And low middle income countries bear a disproportionate burden of children with hearing loss, with nearly 80% of children with hearing loss living in these countries. And Malawi is one of these countries, with previous studies showing that the prevalence of hearing loss in children between 4 to 6 years old was 12.5% in one ear and 24.5% in both ears. So now we'll tell you a bit about Malawi. So Malawi is a low-income country in sub-Saharan Africa, and it is the fourth poorest country in the world. And there's also poor quality of maternal and newborn services. For instance, the nursery ward spaces in all 4 central hospitals in the country did not meet the WHO 2020 standards for delivering high quality of care for small and sick newborns. So now a bit about the risk factors to developing hearing loss. So prematurity is one of the significant risk factors for developing hearing loss. And in Malawi, the estimated prevalence of premature births is 14.5%, which is the second highest in the world. Another risk factor is NICU admission, and the prevalence of hearing loss is remarkably higher in newborns admitted to the NICU, with an increased risk of 1.6 to 13.7%. Also, continuous high noise levels in the NICU have also been identified as a risk factor. And in general, the noise levels in the NICU often exceed the acceptable average sound level of 45 decibels and the allowed maximum sound level of 65 decibels, as recommended by the American Academy of Pediatrics, the AAP, and the WHO. So, newborn hearing screening can identify newborns with hearing loss within the first weeks of life. And according to the Malawian national guidelines, all babies discharged from the hospital should have their hearing assessed. However, not all hospitals in Malawi offer the newborn hearing screening due to a lack of human and medical resources. And various studies have shown that parental perceptions greatly affect the effectiveness of those NHS programs. So acknowledging the parental perceptions of NHS is essential, as they can shape their decision on participation and follow-up care. So addressing infant hearing loss in resource-limited countries like Malawi is very, very challenging, and a critical gap remains in understanding the NICU noise levels and their impact on infant hearing outcomes. And there's also limited research on how parental perceptions of newborn hearing screening affect the prevalence of hearing loss. And therefore, this research aimed to describe the auditory environment in a NICU and evaluate how this might correlate with the infant hearing health. So for this study, we used a mixed method approach, and we aim to evaluate the NICU noise levels and compare it to the recommended WHO and AAP guidelines, investigate the correlation between the noise levels and the infant hearing outcomes, and explore the parental perceptions regarding NHS, so newborn hearing screening, and the NICU noise levels. So this study took place at the Mercy James Pediatric and Intensive Care Unit of the Queen Elizabeth Central Hospital in Blantyre, Malawi, and it is the country's largest tertiary hospital in the southern part of the country. And this study was part of a larger study called Listen and Hear that looked at the prevalence of urban school-aged children's hearing loss in Blantyre. So, like I already mentioned, we used a mixed method approach for this study. And first, the noise levels in the NICU were measured. So this was done by attaching a small microphone to an iPhone, which can be seen here on the right, which was used to measure the noise levels. And the noise levels were then recorded in 2 shifts, from 6 to 12 during the first weeks and between 12 to 6 in the second week. And it measured the average, maximum, and the minimum sound levels over this period. And the reason we only measured noise in these 2 shifts was because of the low battery life of the iPhone. So we couldn't measure the noise for the whole day, but I will get to the limitations briefly later on. So concurrently with the noise measurements, the hearing of the infants admitted to the NICU was also screened. And the target sample size for the infant screening was 100 infants. And we only screened infants that were medically stable. and those infants were screened by a local audiologist, which can be seen here on the right. So for the qualitative part of the study, we conducted focus groups where we discussed the parental perceptions of the NICU noise levels, the newborn hearing screening program, and their infant hearing health, and also other potential risk factors that were associated with our kids' hearing loss. And those focus groups were held in the local language, Chichewa, to ensure that all the participants were comfortable expressing themselves. So now the results. So the NICU noise levels were first compared to the recommended WHO and AAP guidelines to assess the adherence. And in this figure, we can see the average noise levels over all days. So in light blue, we can see the average noise levels in the morning, and in dark blue, the afternoon. And the red dotted line indicates the recommended average noise level of 45 decibels. And we can see that the noise levels exceeded the recommended guidelines on all the days that we measured, with the overall average being 62.5 decibels. This bar plot shows the maximum measured noise levels on all the days of the week. And also here we can see that all of the values exceeded the recommended maximum noise level of 65 decibels, with the average being 92.3 decibels. So during the noise recordings, only 6 infants underwent hearing screening, so way less than we initially anticipated due to a variety of reasons, which I will also briefly touch on later. And the 1 infant who passed the test was neither underweight nor premature. And our main objective was to assess the relationship between the NICU noise levels and the infant's hearing outcomes, which would have provided insights into how changes in the noise levels could have affected the likelihood of a particular hearing outcome. However, this was not possible due to the small sample size. So the results of the focus groups. So we identified several themes from the data, and I will highlight the 2 most important ones, with the first one being missed opportunities in early detection. So parents strongly supported the newborn hearing screening program, and they emphasized the importance of early detection. They also strongly supported it because they wanted to prevent the challenges that come with diagnosis at a later age. And they also highlighted the importance of creating awareness about the program to prevent fears and potential stigma associated with hearing loss. And according to these same parents, continuous monitoring and follow-up by the medical personnel was highly needed. And they said that the hearing loss of their children could have been prevented if the medical personnel acted adequately, and that it's their fault that they did not find out sooner. And this feeling was widely shared among the parents, since none of the children's hearing was tested at birth, and all of the parents were unaware of the availability of these newborn hearing screening tests. Another important theme we found was NICU quietude amidst birth complications. So when asked about birth complications, there were a variety of responses and experiences. And most parents indicated that they believed their children were born without any complications. But there's one parent that reported to have had a complicated delivery, noting that their child was born prematurely and had to be admitted to the NICU. However, they described the NICU as a quiet environment, stating, "No, there's no noise in the NICU. You just leave the children there, and as parents, you just visit them to breastfeed them. Each parent does have her baby by her belly, so there can't be noise that can cause your child to stop hearing." So they emphasized that there was no noise in the NICU that could have affected their child's hearing. So a quick summary of the findings. So we found that the average noise levels exceeded the recommended guidelines, with the overall average being 62.5 decibels, which is 17.5 decibels louder than recommended, which can be perceived by the human ear as 3.4 times as loud. However, the parents perceived the NICU to be a quiet environment. And we also found that 5 out of 6 infants failed the newborn hearing screening test. And because we had such a low sample size, the evaluation of the relationship between the NICU noise levels and the infant hearing outcomes was not possible. Additionally, parents also blamed the medical's personal negligence and lack of communication for their child's hearing loss, but they strongly supported the newborn hearing screening program. So, a quick discussion. So, this study had a remarkably high failure rate. However, this does not necessarily imply that all these infants had hearing loss, since other factors such as vernix, which is the white substance that coats the baby's skin in the uterus, or amniotic fluids from the mother's womb could have also distorted their hearing by clogging their ear canals. And the loud background noise could have also interfered with the test results, as a low background noise between 50 and 55 decibels is needed for a reliable result. However, in our study, the levels were way higher, which could have impacted the study results. And then the limitations, I already touched upon some, but the biggest one was the small sample size. So delay in data collection and operational issues such as power dynamics between departments were the main factors that led to the small sample size. And therefore, we could not conduct the appropriate statistical tests to explore the potential correlation between noise levels and the hearing outcomes. Another limitation was an infection outbreak in a NICU, which resulted in the unexpected deaths of many infants, leading to the head of the unit deciding to stop admitting new patients. And this also resulted in fewer infants being admitted than anticipated. And the babies that were still within the NICU were often too unstable to be screened. And another limitation was the low battery life of the iPhone. So we did not plan on using an iPhone to measure the noise, but due to issues with DHL, we had to opt for this method. And this could have also influenced the validity of the results, since we did not get the full picture of the noise levels over the whole day. So these findings underscore the need for improved awareness and resources to help parents recognize and manage hearing loss in their children. And this includes better parental education, clearer health pathways, and improved communication by medical staff, along with effective noise measurement to prevent hearing loss and the late diagnosis of hearing loss. So for future research, we plan to scale this research up by including more infants while also considering other risk factors such as aminoglycoside intake, which is also a significant risk factor for developing hearing loss, but also congenital disabilities and related family history. And it should also include following up with the children that failed the test. And also, since the loud background noises could have interfered with the accuracy of the infant hearing outcomes, future research should also consider testing infants in a calmer environment. So yes, that was a bit about my project. I tried to keep it as brief as possible. So please reach out to me if you have any questions or you want to know more. But overall, it was a great experience. I'm very, very grateful for the ICHG. And it tremendously helped me grow as a researcher and as a person. And I look forward to being part of the next step within the study and growing as a researcher in the field of child health specifically. And special thanks to my mentor, Dr. Thomas Hampton, and my co-researcher, Wesley. And thanks to you for listening. And yeah, let me know if you got any questions.
Oh, super. Fantastic work. Thank you so very much. What we will do, Sifa, is we will hold your questions till the very end, if that's okay. And then we'll discuss it in the panel discussion. But thank you so much for sharing and for all the fantastic work that you've been doing. We really very much appreciate it. Next up, I'd love to welcome to the stage Professor Özge Karadag. She has very kindly joined us and is come to share with us about participatory approaches in the youth health promotion in humanitarian settings. Professor Karadag has had a vast amount of experience, and so we're very grateful to have her here. She's worked with many organisations, including the World Health Organization and UNICEF and the European Commission, and has held many different governmental, non-governmental roles and working with the organisations for more than 15 years. And she currently co-chairs the Lancet Commission on Health, Conflict and Forced Displacement, and is one of the task force members of the Lancet Migration Euro Hub. We're very keen to welcome her, and I will happily let her share her slides if that's okay. What we will do is we will have this time to have the keynote presentation, and then we will take questions for Professor Karadag. But I am very wary that our next speaker, Caroline Foster, will need to leave us by 3. So we will try and keep all the timing as best we can. Thank you very much. All over to you.
Hello. Can you hear me well?
Yes, perfectly. And your slides are there too. Thank you.
Okay. Thank you so much. And I first would like to thank the International Child Health Group for inviting me for this talk and for organizing this important meeting today. Today, I would like to talk about participatory approaches in youth health promotion in humanitarian settings. So, as you all know, international migration, the number of international migrants globally reached close to 300 million, and currently international migrants represent 3.5% of the global population. And when compared to 2000 or even 1980s, you will realize that the number has increased a lot. And when thinking about international migration and how we as health professionals work towards international migrants' health and health equity, we actually probably should focus on 3 SDGs, although there are more SDGs, Sustainable Development Goals, that we can consider. The first one is obviously SDG 3, that is about health, healthy lives, and promoting well-being for all. SDG 10 is about reducing inequalities within and among countries, and SDG 16 is about promoting just, peaceful, and inclusive societies. And I think these 3 SDGs are extremely important when thinking about international migration, its relation with health, and we as health professionals when working on refugee and migrants' health. So when thinking about international migration, obviously we think about economic labor migrants and then forcibly displaced populations. And when thinking about migration and health relationship, obviously the type of migration is very important. And of course, forced displacement is especially important because it's one of the most significant results of man-made disasters throughout history. And now looking at the numbers, we have approximately 110 million forcibly displaced people around the world. This means 1 in every 74 people in the world has been forced to flee, and that's a very high number. And when we look at figures for displaced children, according to UNICEF, worldwide, about 47.2 million children have been displaced due to conflict and violence. That's a very huge number. This number includes 19.1 million refugee children and asylum seekers, 28.1 million children displaced within their own country by conflict and violence. And in addition, we have more than 3 million children living in internal displacement as a consequence of natural disasters. So when thinking about all these children and, of course, youth, young people, we as health professionals have a role in both preventing diseases and promoting the health of these populations. And health promotion, as you know, is the process of enabling people to increase control over and to improve their health. And health promotion is very important for all ages, but especially for children and young people, since all those interventions that increase health literacy and promote healthy behaviors are important for children and young people to have healthier lives. And 5 action areas, according to the Ottawa Charter for Health Promotion, is building healthy public policies, creating supportive health promoting environments for these children and young people, strengthening community action, meaning participatory approaches in healthcare, developing personal skills, meaning increasing health literacy and promoting healthy behaviors, and then reorienting healthcare services is very important. And when we think about youth participation or engagement or involvement in healthcare policies, practices, and research, we mean that we involve young people in planning, implementation, and evaluation of these policies, practices, or research. And it's very critical to include communities with vulnerabilities in our work, because they can identify solutions, help ensure compliance, and they can also help us tailor responses to meet the diverse needs of populations. And why do we need to involve communities, and in this case, obviously, young people, to be able to have a culturally sensitive health research, policy, or practice. And also, we need our research, policies, and practices to be based on real needs of communities. We also want to raise awareness among young people about their own problems, own health problems and needs. And we also want to increase acceptability of our health research, health policy, or health promotion practice. We want to increase trust between healthcare professionals, health researchers, and young people. And also, we would like to increase the level of participation. Participatory approaches also help us with better identification of motivations and barriers among community members, especially when thinking about behavior change. It helps with increased positive change in norms, attitudes, and behaviors. It helps with increased control of the community members over their life. And I think this is really important. Participatory approaches also help us with empowerment of the communities, increase their problem-solving skills, increase their self-esteem and feelings of being valued. I think that's really important with participatory approaches. And the last thing, but not least, is participatory approaches also help us improve social relationships, bonds, and social resilience among the communities that we work with. And as a research approach, community-based participatory action research, which actually comes from social science, but we now use it a lot in health sciences as well. This approach has been recognized as an approach to conduct research with rather than on communities. It's a collaborative research approach that involves community groups, policymakers, decision makers, and researchers. And there's shared decision making and ownership when compared to the traditional ways of doing research. It combines knowledge with action, advocacy, and this kind of action research approach also aims to create a social change to improve public health and to decrease health inequalities. So CBPAR projects also ensures that the community participates fully in all aspects of research. And obviously, action must be done with people. And as an example of this community-based participatory action research, photo voice is one of the methods that we use, which actually is a process by which people can identify, represent, and enhance their community through a specific photographic technique. So in this research method, we combine photos with voices of people, in this case, obviously young people. And Photo Voice has three main goals. First, to enable people to reflect their community's strengths and concerns, to promote critical dialogue, and also to reach policymakers, because it's again an action research. We want to use the findings to reach out to policymakers to change health policies and programs. So I'll give you an example of a photo voice research example from Turkey. This is one of the studies that I conducted in southern Turkey, Hatay, to basically assess the needs of young Syrian refugees on health, education, employment, and gender issues. This was actually a mixed method study and supported by UNFPA office in Turkey. So we first started with a quantitative needs assessment by visiting households and surveying young refugees between the ages of 18 to 30. And then this was followed by a qualitative photo voice study to have a more detailed picture of living as a young refugee in Turkey. Sorry, I think my slide didn't change, but okay. Can you see my slide?
I can just see blank at the moment, but if you see, okay. If you take it up again, and I'll download in the meantime.
Okay, let me try to. Okay, there were photos of this study, which we conducted with young refugees and also local youth in Turkey. But maybe, let me try, maybe the photos are not here, but I can continue with the slides. Okay, I'm still...
apologies, they still look blank.
Yeah, still blank. I'm just trying to see if we can pass to the other slides. I think we can't.
That's okay. If you'd like to take them down, I can share if you like.
Yeah, okay. Let me then stop sharing. And then, yeah, we can have the slides, try the slides again. But I can continue talking about our findings. So we worked with groups of refugee and local youth. We wanted to have mixed groups of young people in this case, because we thought that it could be really good if we bring together local and refugee youth to work together and to discuss their barriers in accessing health information, health services, and healthy environments. And actually, during this study, and basically when sharing and discussing the findings, we found out that actually there were a lot of common problems in accessing youth-friendly health information and services for both local and refugee young people. And actually, this study also helped us helped with the social cohesion of young refugees. And also, they had the chance to see that they had shared problems, and it also helped us to basically use these findings to advocate for young people's health and for youth-friendly services in Turkey, because by using these photos and quotes from the participants, we had a lot of photo exhibitions in Turkey where we invited UN agencies, humanitarian organizations, other non-governmental organizations working with forcibly displaced populations, academics, researchers, and municipalities. And we also had a lot of media coverage as well. So these photo exhibitions, those photos and live panels with young refugees helped us to raise awareness raise awareness about the problems that young refugees faced in terms of accessing health information and healthcare. So I don't know if should I try again? Oh, okay. So I think now we can see the photos. Let me. Oh, okay. So I think. So these qualitative photo voice studies showed that despite legal rights, young refugees faced language, financial, social, cultural, and educational barriers, as well as gender and stigma-related barriers in accessing healthcare services. And we had a lot of themes like unhealthy living conditions, nutrition and hygiene problems, barriers to accessing education, child labor, early marriage, adolescent pregnancies, and high mobility, uncertainty, and related mental health problems. So this is one of the posters for our photo exhibition, which was again supported by UNFPA office in Turkey, and some of the photos showing living conditions, young refugees working as public porters, and young people who have problems with accessing higher education. A lot of photos on child labor with very small wages. And this photo is showing school kids, although the building is not in a, there are physical barriers. The students look happy because they have access to education. This photo, for instance, shows staff luggages, and the young person who took this photo was talking about how they have instability and how the refugees were in a state of moving and a constant state of departure, and how this affected their mental health, the uncertainty. This is one of the newspapers covering the photo exhibitions and the findings. So in these participatory approaches, doing advocacy with the affected populations is very important, and dissemination of findings beyond academic meetings and publications, and informing decision makers and policymakers about research findings is important, because that advocacy can really create a real change. And in this situation, working with mixed groups of refugee and local communities really helped us strengthen social ties, and it helped us build a shared environment between local and refugee youth. This is one of the book chapters that I wrote about this study, freely downloadable. And in the second part, I also want to show you one example how we used participatory approaches in youth health promotion by actually creating a digital application, mHealth application for young refugees. So as you know, again, science, technology, and innovation, together with financing for development, were identified by the UN as one of the two main means of implementation to achieve the SDGs. That's why using technology is really important. And recent studies with refugees show that many refugees use smartphones and internet for daily communication. That's why now many organizations are using these technologies to improve health services for refugees and conflict-affected populations. So in this project, we co-designed a mobile health application with refugee youth. And in this participatory project, we worked with refugee and local youth groups to identify problems, needs, to advocate for their health rights. And then we worked with young people to co-design the application. And then we actually employed young refugees to work as digital health mediators. So we used the peer-to-peer approach in reaching out to other refugee youth. And then, of course, we worked with young people and youth organizations to organize events and use social media to disseminate the findings and the digital application. So the lessons learned, one of the lessons learned was that health promotion interventions need to respond to the needs of young people, be evidence-based and culturally appropriate. Youth-friendly characteristics are also important, and peer-to-peer or youth-to-youth approaches are very effective in facilitating access to reliable health information and health services. Again, using participatory approaches and co-design approaches are very important, and youth-adult partnerships are also very important. So these are my last slides, but I wanted to conclude by saying that when talking about, for instance, technology and sustainable development goals, we need to talk more about new education opportunities, new job opportunities, and ending poverty, especially for children and young people. The job opportunities are obviously for older young people, but improving access to education, healthcare, and social care, increasing access to clean water, sanitation, healthy food for young people. Also, we need to talk more about climate change and how technology can help us to reverse it for better children's and young people's health, and also how we can use technology to better respond to disasters and help disaster survivors, including children and youth. And also how we can use technology to promote healthy cities, youth-friendly cities, and social cohesion between local and displaced populations. Also, reaching out to vulnerable and disadvantaged youth is possible by using, technology and to decrease inequalities. But to be able to do that, we, of course, also need to work on decreasing the digital divide and to ensure equity in access to internet and digital devices for displaced populations as well. Lastly, using technology in conflict resolution and peacemaking is also important. And as you know, the World Health Organization also has really good initiatives now on global health interventions and how we can basically use health interventions for peace making. Here are several commissions and networks that I would like to mention before I conclude, like Lancet Migration Europe Hub, CHH, Lancet Commission on Health, Conflict and Forced Displacement, the Migrant and Refugee Health section of the World Health Summit, European Public Health Associations, again, section on migrant and ethnic health, and American Public Health Associations, again, section on refugee and immigrant health. Here is our website for the Lancet Commission on Conflict and Health and Forced Displacement, and our paper, which actually introduces the Commission and its aim. So thank you so much for listening to me. And if there are any questions, I'd be happy to answer. Thank you.
Thank you so much. What a fantastic talk. And thank you so much for keeping going, even when the technology had not quite worked so well. It was lovely to see all the photos of the young people involved in the work. There's a couple of questions on the chat, and I've got one as well. Shruti asks, and says, thank you so much for the insightful presentation. She wondered, what has the response been from the young people involved in working on the app and the program?
Mm-hmm. So we actually got a lot of feedback from the young people, both qualitative and qualitative. Actually, they were really happy, first of all, to be part of this first participatory research, and then co-designing a health intervention and then an application. And then actually during implementation of that digital app, because they were the ones basically supporting the application by this peer-to-peer approach and working as digital health mediators. And then during evaluation as well, because we also evaluated how the impact of this app increasing health literacy and access to healthcare. So they were actually part of planning, implementation, and then evaluation. And they said that, first of all these, active engagement made them feel more empowered. They had the chance to work with adults and, senior health professionals and researchers. And they said they actually, this whole process for several years and their active engagement increased their health literacy and advocacy skills, and how to work with NGOs and how to work with UN organizations, universities, to reach out to decision makers, to advocate for their health rights. And also, they said that it helped with their digital skills as well, because this was a digital health project. And also, it actually made them realize that they share a lot of common problems with local youth. And they had really good friendships. It was also an environment with, sustained relationships between local and young people who participated in this process. So overall, it was really, really positive. And we really encourage, future health research, especially with displaced young people, to, use more participatory approaches.
That is great. And I guess that leads on to a question that we had as well around that working together of the young people. Did that help break down some of the discrimination and the stigma that was associated with migrant population? Yes.
So, of course, the photos during the Photo Voice study, there were a lot of photos showing barriers in accessing healthcare, and we talked a lot about stigma and discrimination because that was one of the main themes actually. And when disseminating all these findings in our exhibitions and in our panels, we always involved young people who took part in these studies to talk about the findings, etc. And I think, during those panels, exhibitions, and also with the publications and our visits to the Ministry of Health and other UN agencies in sharing findings, I think we raised a lot of awareness about this stigma and discrimination. And the media coverage was, I think, also really important because we had a lot of newspaper articles, etc. So I think it helped with at least decreasing the stigma for the populations that we reached out.
That is fantastic. Thank you so very much for all of your insight and the work that you've been doing. We really appreciate you sharing with us. And there's a question in the chat that Benjamin has put about ethical dilemmas. But I wondered if you might, whether I could trouble you to reply to that in the chat, Professor Carriger. Thank you so much. I'm going to hand across, I think, to Daniela now, who's going to introduce our next speaker. But thank you for joining us.
Thank you. Thank you so much again. Thank you. Bye-bye.
So it's my privilege to introduce our next speaker, Dr. Caroline Foster. Dr. Foster is a consultant in adolescent infectious diseases at Imperial College Healthcare NHS Trust in London, and she's also chair of the Perinatal Virtual Clinic. She's involved in international education, and her research interests include outcomes for young adults with perinatal HIV. Today, Dr. Foster will be speaking to us on the Perinatal HIV Virtual Clinic, supporting complex case management. Now, I would be very grateful if you could put any questions you have for Dr. Foster in the chat, and we will try to, if we have time, to ask her straight afterwards. Otherwise, we will be forwarding the questions to her. So, Dr. Foster, over to you.
Thank you very much. That's very kind, Daniela. Thank you for asking me to speak. I'm really hoping that this is going to work. And that you'll be able to see the slides. If not, okay, they're coming through. Lovely. So I'm going to talk you through our model of virtual clinic case discussions for the Perinatal Virtual Clinic. So this is a group of multidisciplinary healthcare professionals, mainly based at Imperial, aiming to support complex case management for pregnant women, infants, children, adolescents, and young adults living with HIV. And it's run as a once monthly Teams meeting. First Thursday of the month. You could have joined at 8:30 this morning. We had 10 fascinating and complex cases. It's an anonymized open discussion forum with multidisciplinary healthcare recommendations. Also, between the monthly meetings, we provide real-time email discussions, say for pregnant women recently diagnosed with HIV, what to give the infants. And it's a collaboration between those in high-income settings with low numbers of children now living with HIV, and those in high-income and low-income settings with high numbers of children who are now accessing a wider combination of antiretroviral therapy and are getting access to resistance testing, but we can draw on the experiences from all settings. And the journey for this started with adults had virtual clinics, not perinatal virtual clinics, from 1999, looking at the regional sector in the UK. And they would, given the number of patients, they would meet 3 times a month. And it actually became a requirement to discuss complex cases either in a virtual clinic or in a multidisciplinary. So we started the Perinatal Virtual Clinic in 2009, initially in the UK and Ireland. once a month. It's grown from an hour to 90 minutes, and we discuss about 10 cases, and it's supported by the Children's HIV Association in the UK and in South Africa, and by the PENTA, which is the Paediatric European Network for the Treatment of AIDS, which runs global HIV education and research programs. And this is the typical format. This is actually the adult, this is my adult virtual clinic from last week, where we discuss complex case histories. And the reason this came about is I started as a paediatrician with an interest in infectious diseases. Well, I trained in infectious diseases, but 25 years ago, we were just getting access to antiretroviral therapy, yet 17 years ago, the oldest young people were leaving pediatrics and going into transitioning into adult care. And they found it really hard to settle. They felt judged by the other patients in the room who may be in their 40s. They felt it difficult to go to a sexual health service for their HIV care when they themselves had never had sex, for those that were in that situation. And so we decided to transition the paediatrician, and I went and was taught by the adults about adult HIV and have been a consultant, half funded by pediatrics and half funded by adult HIV. But the great thing about working with your adult colleagues in a speciality is they see very much larger numbers, and they have excellent structures that you can basically pinch. So we pinched their adult virtual clinic and made it into the pediatric one. And discussion for complex cases is now also a standard required by PENTA guidelines, so that's the European Paediatric HIV guidelines, and by the UK CHIVA standards. And you know, why is this important? Well, if we think globally, 11 million infants have been born with HIV from 1990. Many of those in high-income settings are now well embedded in adult care. The oldest young person I look after who was born with HIV is now 40. And whilst there's been huge progress in the prevention of vertical transmission of HIV, we're still seeing about 120,000 babies infected every year. And they are joined by a large number of adolescents who acquire HIV during their adolescent period. And when we're thinking about equity between paediatric and adult care, you can see that 77% of adults globally have access to antiretroviral therapy, whereas only 57% of children do. And the licensing of antiretrovirals for children lags behind adults by about 8 years. So kids are having less effective, older, more toxic regimens for on average 8 years compared to adults. And whilst we've made huge progress in HIV, the progress has actually stalled, and actually the gap between adults achieving a suppressed viral load, which is great for your own health, but also renders you uninfectious, zero U equals U, zero risk of transmission, and that's incredibly important for our adolescents. But you can see that the progress for pediatrics has really stalled. Part of that is COVID, but part of that is a recognition of the difficulty in access for kids dependent on carers. And often, if you are born with HIV, your carer may be unwell themselves, or you may well be an orphan. If we look in high income settings, what you can see in the green bars is that's everybody over 20. So there are very few kids left in pediatric care in high income setting. And that has its problem too, in that HIV first came to high income settings really in significant numbers at the sort of 1997. And therefore that group of pediatricians have now started to retire. So we are now newly diagnosed children are looked after by pediatricians who may have had very, very little experience in their setting of looking after families living with HIV. And that's the need for shared expertise in the virtual clinic. So it's super easy to refer. We have a referral slide bank for children, infants, children, and adolescents who are living with HIV. And we have a referral slide set for vulnerable pregnant women. And this is just an example of a recent case from Katie Simon in Malawi. So this is what we do in the virtual clinic. Whoever submits their case then presents it if they can. If not, somebody will present it on their behalf. But this was a 6-year-old living in Africa, weighed 90 kilos, born with HIV, who'd experienced weight loss and night sweats, and a diagnosis of probable tuberculosis was made on the basis of ultrasound findings of splenic microabscesses and abdominal lymphadenopathy, although the urinary LAM was negative. But a clinical diagnosis with ultrasound support of extrapulmonary TB, standard quadruple regimen. And there, the team's question was, what's the best antiretroviral therapy for this child on TB treatment, given that they'd had resistance testing and it showed triple class resistance? So this is how the child's doing now. CD4 count isn't bad, has a viral load that's moderate, certainly not suppressed, and is on dolutegravir. And because they've started rifampicin, they have doubled up the dose of dolutegravir because of the interaction with rifampicin. And this is the child's treatment history. They started on nevirapine, which is a very fragile regimen of an NNRTI that if you fail, you very rapidly get resistance. They then went on to lopinavir-ritonavir, which is a boosted protease inhibitor, which was the standard second line in sub-Saharan Africa for that age group at that time. And then when dolutegravir, which is a second generation integrase inhibitor, became available, they transitioned to that. But you can see that bar one in 2021, they always had detectable viremia. And if you have detectable viremia when you have low-level antiretroviral therapy, you will rapidly select out resistance mutations. We use something called the Stanford database, which we do online. And one of the great things about the virtual clinic is we can help people who are new to resistance testing with their interpretation. So you can see that this child has triple class resistance to nucleosides, to non-nucleosides, and also to integrase inhibitors. And the problem, so that child needs to probably go on a boosted protease inhibitors, but the problem with that is there are very significant interactions and the dosing is incredibly complex with a boosted protease inhibitor and on antiretroviral therapy. And this is the wonderful pictures from the Liverpool Drug Interaction website. You may be familiar with it for HIV, hepatitis, COVID drugs, looking at potential interactions. And that's Neil, who's our specialist pharmacist, and the importance of having access by email to a specialist pharmacist when you're dealing with drug interactions. And I think that's another great thing about the virtual clinic is that we won't know the answer, but we can link you to global experts that may well be able to help. And that's also really important in rare presentations. So today we discussed a child in Uganda who probably has SSPE related to measles, which is very rare in the context anyway, but it's very rare in the context of HIV, but we can link to people who have some experience. So this was the recommendation for that child, an acknowledgement that it is very complex, these sorts of decision-making process. There's a lot of responsibility if you're an individual clinician trying to decide, and we discuss potential treatment options, including switching the rifampicin for moxifloxacin, but that gives you a much longer duration, and you have to think about the child. So your much longer duration of TB therapy, that's multiple therapies. How does that work for this child who is already failing treatment, already is showing, because they've acquired resistance, that they have poor adherence? You know, how are the interaction with the carers, who's giving them the medication, etc., and trying to keep drug toxicity down, but also pill number and burden down. we have the virtual clinic's been going since 2009. We have published, Kirsty Ledoir assessed the first sort of 4 years, and you can see it was very UK and Ireland, but by 2013, 15% of the referrals were from low middle income settings. And that's when we were doing it by email and no Teams. COVID has at least dragged us into the Teams generation, but we were doing these discussions by group email, which we still do between meetings, and we'll have mini MDTs. We're now, it's between 35 and 40% are from low middle income settings, but we have cases from Iceland, from Denmark. Today we had some from Sri Lanka, from Chile, and it's amazing to hear experiences from a really wide range of settings. We have recently been looking at the complex resistance and have just published a case series in AIDS looking at emerging integrase resistance. This is super important because globally dolutegravir, second generation integrase inhibitor, is being used both in first and second line from 4 weeks of age right through to year 90s. So that sort of surveillance and describing the risk factors for acquiring resistance. Most kids who fail dolutegravir do not acquire resistance, but those who are treatment experienced, as in the child with TB, are the ones who we rapidly see the potential acquisition of integrase inhibitors. It's not only about the children, it's also about a mum. So we'll often get referrals about a mum who's, say, 32 weeks pregnant. She is struggling to take her own medication. She's got a detectable viral load. And we look at how can we improve mum's management. And often, actually, that's a de-escalation of pills because people have been adding things in and giving her one fixed dose combination. Does this woman need a cesarean section? That's if her viral load's above 100. And then what are we going to give the baby? Are we going to give the baby single agent, but in this setting, a high risk triple agent? And depending on where you're setting, what access do you have in terms of access to infant formulations and antiretroviral therapy? And that obviously very much depends on your global setting. So this is looking, the grey is what we would do in Europe. The darker colour is what would be given in, say in Uganda, so 6 weeks of azathionevarapine. So we also talk about, so in the majority of the world, in a low income setting with unsafe access to clean water and formula feeding, breastfeeding is very much better for all babies, irrespective of the mother's viral load. Consensus in high income settings about breastfeeding is changing. There is a more support to breastfeeding. But this is a common question. Mum's been undetectable. She's breastfeeding. The baby's 5 months old, and mum then has a viral load that's not less than 50 and it's 128. What do you do? And we have a lot of discussion around this about whether this is the threshold for stopping breastfeeding in our setting. Would we then give the baby postnatal prophylaxis for 4 weeks, given that they have now had an exposure? And unlike sexual transmission, where having an undetectable viral load below 200 is zero risk, we know that in pregnancy and in breastfeeding, that isn't quite the same. U is not quite equals U, and that's probably because cell-associated transmission. So, and that's really complicated, assessing that risk for mums living with HIV who want to do the best for their baby in our setting where there is safe formula feeding, but they would rather breastfeed. And sometimes that's about breast is best for baby, but it's also about my mother-in-law doesn't know that I live with HIV and she would culturally expect me to breastfeed, given that many of the women living with HIV in high income settings are from migrant populations. So this model has been going within HIV in the UK and with our global friends since 2009. But over the last couple of years, it's spread out. There's a similar model for TB. And this is Hermione Lyle, who chairs, or who used to chair, actually, she's just handed over, the CCMVNet, which is a very similar monthly meeting. We use the same slide bank for referrals to advise on the treatment, management and investigation of CMV, including valganciclovir. So really, in summary, the perinatal virtual clinic, the aims are that it's to support decision-making in complex case management in perinatal HIV. It's to maintain the expertise in high-income settings. That is, is falling given the reduced number of kids, but those kids who come through are often very complex because they're often women who have declined HIV testing in pregnancy or have not taken treatment for themselves. But it's also a recognition of our desire to want to support people in our colleagues around the globe in high prevalence, low resource settings who are now having access to resistance testing and a wider array of antiretroviral therapy. So there's more choice. There's first and second line based around dolutegravir, but there is now a wider choice. And really building global networks of easily accessible specialists and trying to just link up and make great communication. And that is our merry band of virtual clinic. We've got two of our adult colleagues there, Nikki Mackey, who's an expert in resistance, but also an adult HIV physician, and Angela Bailey, who is a specialist in opportunistic infection and an adult HIV physician. And then we've got our sort of pediatric and adult healthcare professionals, including our pharmacist, Neil. So that is my run through. Shall I now try stop sharing? And happy to answer any questions.
Thank you so much, Dr. Foster, for a fantastic talk. It's just exciting to see how, I guess, with technology now, first email, now Microsoft Teams and video conferencing, that we can collaborate across borders and discuss these complex cases. So thank you for shedding a light on that, and also shedding a light on the gap between children and adults and the outcomes that we are reaching with HIV, which with children is lagging behind. I have a few questions in the chat that just before you have to run, I'll briefly ask you if that's okay.
No hurry.
So I've got one from Helen. She says, "Thank you, Caroline. Very interesting to hear about the virtual clinic. Would be fantastic to replicate the model for other conditions too, like complex neonatal cases with colleagues in other countries. How did you convince your trust to fund it when patients are not in the UK?"
It's not funded.
Okay.
I've never been, I do clinical medicine, which I absolutely love. I've looked after some of my patients for 28 years. It's been an amazing journey and a privilege. And I do research and I do education. I don't do business plans. So we just set it up and we sort it out ourselves. That's why we have a referral slide deck, because I don't have time to make everybody's slides from them emailing me information. They do their slides, I amalgamate them. And it's unfunded, but I don't really see the need for funding. We're all happy to donate an hour and a half of our time. I did start at about 5 o'clock this morning, sorting out the slides for the late comers, but that's absolutely fine. We all get so much out of it. We learn, the group in the PVC, we feel we learn a huge amount. We gain more than we give. And actually, it's not very time consuming and there's no expense in it. And therefore, nobody in the trust has ever said to me, it'd be really difficult to say you've got to stop doing it. They wouldn't dare. Give them a good go. Anyway.
It's really lovely to know that you've been doing it out of the goodwill of your heart and that you get a lot out of it. I think a follow-on question from that is, how do you select which cases to discuss and which ones you maybe don't have time for?
So it actually, it's a good question. It's It's quite balanced. It usually is between 10 and 12. I mean, I chair it, so I get a bit, we've got too many cases, stop, no more teaching, because we do quite a lot of teaching around. So Nikki Mackie, who does the resistance, will teach a bit in how do you interpret the mutations, because this is a new tool for many of the healthcare professionals that are joining the virtual clinic. So it does impinge a bit on the teaching, but it's usually, occasionally I bump a non-urgent one to the next month, and occasionally we do them between. But we used to be an hour a month, and we went up to an hour and a half because there were more cases coming through. And yes, there will be a discussion if we need to do, a second one a month, but at the moment it's pretty balanced.
And one last question. How quickly is HIV drug resistance growing as a problem? And is the biggest contributing factor drug adherence or access to appropriate drugs?
So, I mean, yeah, I think so. HIV drug resistance, if you start a current modern second generation integrase inhibitor based regimen, your risk of getting resistance is very low. Okay, if your adherence is pretty good, your risk is low. So the resistance is much higher in, the young adults I look after who've been born with HIV, who are now in their late 20s and 30s, have a lot of resistance because they got really poor drugs. We started with dual therapy. We didn't have proper triple therapy. So, but we still see, that child that I presented is only 6 and has got 3-class resistance already. So it's not, there's a huge problem with what we call NNRTI resistance globally, because that's what little kids had in the way of nevirapine and then efavirenz. And, whilst we may not use that class anymore, actually the long-acting injectable therapies, cabotegravir and rilpivirine, if you failed NNRTIs, even if it was 20 years ago, you can't have the current long-acting injectable. So what happened to you a long time ago impacts your options. And I think that's another very nice thing about the virtual clinic is we do have good links with pharma between us all, and we do access compassionate use drugs. So there is a 6-monthly subcut injectable called lenacapavir, which we have managed through, the virtual clinic to get access. We've also, places like the Philippines that didn't have access to dispersible dolutegravir for infants, we've managed to help link to expedite that into the country. So I think, driving policy of equitable access to drugs is a really important part of our role in advocacy for kids and for families living with HIV. And there was a comment, if anybody wants to join the virtual clinic, because all the cases are anonymized, it's a Teams meeting, so anybody who's interested in HIV care can join. And the way to join is, don't all bombard me with an email, is to email me at caroline.foster5@nhs.net, and I can add you to the group and forward you to the link. And it's the first Thursday of every month at 8:30 UK time in the morning till 10. And everybody is extremely welcome.
Thank you so much. Sorry, I had skipped over that one. So that's great, and open invite. I've actually sat in one of your clinics before, but not the virtual clinic. So I'm sure it'll be a fantastic learning opportunity. So thank you so much again for your time, Dr. Foster. I think we'll be moving on now to our next speakers. I am just waiting for them to be moved to this stage.
Thank you very much.
Thank you. So our next speakers are the ThruZim team. ThruZim stands for the Health Research Unit Zimbabwe, and it's my privilege to welcome them. So it's Dr. Martin, Miss Ndondo, and Dr. Austin. Dr. Martin is a clinical research fellow currently undertaking a PhD in point of care testing for STIs in antenatal care. Ms. Ndondo is a social and behavioral scientist with a focus on adolescent sexual and reproductive health and the intersections of HIV, AIDS, TB, and mental health. And Dr. Austin is a pediatrician in the leading malnutrition unit at Sally Mugabe Children's Hospital and is also a technical project manager for UNICEF. The ThruSim team will be speaking to us on the Kids with Kids study, exploring the vulnerabilities and experiences of pregnant and postpartum children in Zimbabwe. We're so excited to hear from you on your work. Over to you.
Thank you very much. So I'll just try and share my screen. Is that presenting okay?
Yes, it is. Fantastic.
So yeah, great. So yeah, thank you very much to the International Child Health Group for having us. My name's Kevin. As I was mentioned, I'm a clinical research fellow at London School of Hygiene and Tropical Medicine and the Health Research Unit Zimbabwe. And together with my colleagues Noni and Lana, we'll be presenting the Kids with Kids study that explored the vulnerabilities and experiences of pregnant and postpartum children in Zimbabwe. Just to give a brief overview of the talk, first I'll talk through the background, the aims of the study, our methods, and some brief quantitative results before handing over to Noni, who will talk through the qualitative data, and then Lana will talk through the discussion and policy implications of our findings. So just to start, why is pregnancy in children important? Firstly, we know that there's a risk to maternal health. Those aged 15 to 19 years of age are twice as likely to die during pregnancy or childbirth compared to women over 20 years of age. And those aged under 15 are 5 times more likely to die during pregnancy or childbirth. Similarly, children who become pregnant are at higher risk of complications like eclampsia, puerperal endometritis, and systemic infections compared to older individuals. There's also implications for the babies who are at higher risk of being born below birth weight, premature, or being in a severe neonatal condition, with higher levels of infant and child mortality among children born to child mothers. And additionally, pregnancy itself in a child is potentially an indicator of a child being highly vulnerable and at risk of other concurrent conditions such as HIV infection, other sexually transmitted infections, common mental conditions, malnutrition and anemia, all of which then feed back into and exacerbate the existing maternal and neonatal health risks associated with pregnancy in children. It may also be an indicator of a child who's been in a transactional or exploitative relationship, and they may have been shunned by family as a result of the pregnancy. And finally, there's the future implications. So not only do these children have to live with their pre-existing vulnerabilities that may have led to them becoming pregnant, but now they have to raise their own child in systems that aren't necessarily designed for them. And due to both the vulnerabilities that predispose children to becoming pregnant, as well as the impacts that pregnancy has on their life going forward, pregnancy in children straddles many of the Sustainable Development Goals. And this includes the relationship of child pregnancy with poverty, with nutrition, as well as directly with maternal and neonatal mortality. And furthermore, access to comprehensive sexual and reproductive healthcare services, education, and employment, both influence and are influenced by child pregnancy. And so what's the current evidence base? So regarding kind of data and policies and strategies, there's actually quite a lot of global evidence supporting activities to prevent pregnancy in children. However, once a child becomes pregnant, the data is definitely a bit more sparse. So this 2023 scoping review by Ajahi et al. Found that research on lived experience of pregnant children in Africa has been limited in both scope and geographical coverage. And as you can see from this map of the continent, the bulk of research has been from 2 countries, so South Africa and Kenya. And there's also been a more recent assessment of adolescent pregnancies in Zimbabwe in 2023, compiled by UNICEF, which found that overall 21% of antenatal bookings in Zimbabwe were among those aged 10 to 19, and particularly starkly, prevalence of pregnancy among 15 to 19-year-olds was over 40%. But gaps still remain, particularly when we think about prevalence of non-HIV sexually transmitted infections in this group, mental health assessment, and also there's a lot more scope to do more in-depth assessment of the lived experiences of pregnant children. As a result of this, the objectives of our study were to investigate prevalence of sexually transmitted infections, maternal mental health, and other markers of physical health and vulnerability that affect pregnancy outcomes in pregnant children in community settings, to investigate birth outcomes for child mothers and their infants, and to explore the needs of pregnant and postpartum children through their own lived experiences, the perspectives of their support systems, healthcare providers, and other key stakeholders. So to do this, we conducted a prospective interventional study that took place in Epworth in Harare province, and Epworth is a commuter town just southeast of the capital city of Zimbabwe, Harare. And we enrolled pregnant children who were below the age of 18 years of age and who'd been referred in by community child workers or staff at the Epworth Clinic, and they referred to our team who were based in Epworth Clinic itself. And for those who were referred in, they were enrolled into the study in a consecutive manner. And those who were enrolled and provided written consent were then able to take part in the study procedures. And this included being referred into routine antenatal care services and having their fees covered, which during the study itself at Epworth Polyclinic were $40 for antenatal care, and being linked in with social services and been referred for counselling services through the Friendship Bench service. As well as having an ultrasound dating scan and then being referred for obstetric or paediatric specialist assessment if required. Alongside this, we measured their hemoglobin, blood pressure, blood glucose, did a urine dip, and measured height, weight, and mid-upper arm circumference, and collected demographic data, and screened them for HIV, hepatitis B, and syphilis using finger prick blood tests, and for chlamydia, gonorrhea, and trichomoniasis using self or provider collected vaginal swabs. And assessed their mental health using 3 different scoring systems, so the Patient Health Questionnaire 9, the Shona Symptom Questionnaire, and the Edinburgh Postnatal Depression Scale, and provided folate and iron supplementation, a food hamper, and then also a birth pack containing baby clothes, other essentials, as well as medical tools if for the delivery phase, if not available within the clinic or facility where they delivered at. And we also followed up those who were enrolled for their birth outcomes and for preterm birth, low birth weight, miscarriage, stillbirth, and neonatal death. Alongside this, we included a qualitative component, and this was based primarily on in-depth individual interviews, done in 3 waves in March, July, and October of this year. And the main focus of this was 11 pregnant and 7 postpartum children who were enrolled from the main cohort. And really the approach was child-centred, giving them the space and time to tell their own stories with an emphasis on understanding and support. For those children who also gave us permission, we spoke to some of their next of kin, including 4 of their mothers, 2 of their partners, and 4 other female relatives, as well as community health workers and healthcare workers. And this data was all analysed thematically with an iterative approach and triangulation across datasets. So now I'm going to present some of the quantitative results, and really what this is doing is setting the scene more for the qualitative data, which then really delves into some of the themes that will come out. But we had 126 potential participants referred into our study team, of whom 119 were eligible, all of whom were enrolled, and we were able to follow up 115 for birth outcomes. And in terms of the demographic data for this cohort, so the 1 12-year-old was enrolled, 1 13-year-old, 1 in 3 were age 14 or 15, and 2/3 were 16 or 17. Only 1 participant was still in education at baseline, and about 20% had left education as a result of the pregnancy. But particularly importantly, actually almost 80% had already left education for a reason other than their pregnancy. Almost 2/3 reported that they had to cut the size or skip meals due to lack of money in the last 12 months. Over 90% reported no relationship with the father of the child at present. Just under 90% said they did not want to become pregnant, and a further 6% would have preferred to put it off. 3 reported condom use at the time of pregnancy, but the remainder said that they hadn't used any contraception at all. And over 1/3 said that in the past 12 months they'd been humiliated, threatened, insulted, or physically assaulted. In terms of screening, almost 40% tested positive for at least 1 curable STI, so that's one of at least chlamydia, gonorrhea, trichomoniasis, or syphilis. And chlamydia prevalence was 26.9%, trichomoniasis was 16%, gonorrhea was 8.4%, and syphilis, one participant tested positive. There was no diagnoses of hepatitis B, and HIV prevalence was over 10%, one of which was a new diagnosis within the study. And then just based on one of our scoring systems for mental health, for depression, 14.3% scored for moderate depression, 13.5% for moderately severe depression, and 9.2% for severe depression. And finally, for the quantitative results in terms of birth outcomes, so of the 115 we were able to follow up, there were 108 live births, so that was 107 singletons and one set of twins. There were further 5 live births and unfortunately did not survive the neonatal period, so 5 neonatal deaths. There was another set of twins, both of whom were born stillbirth, 1 miscarriage and 1 termination of pregnancy. And then in terms of prematurity and low birth weight, 1 in 4 were born premature. From the live births, 14% were low birth weight, and of the 5 neonatal deaths, 3 were born premature and 2 were low birth weight. And so now I'm going to hand over to Nonny, who's going to talk us through the qualitative results.
Thank you, Kevin. I don't know if you can hear me. Okay, thank you so much, Kevin. My name is Nonhlanhla Ndondo. I was a social scientist together with Dr. Sarah Bernays, who collected the qualitative data. Next slide, please. For this cohort who we recruited for the qualitative data, most of our participants were age 16, but we did have some who were 14 and 15 years old. Next slide, please. So I'll delve right into the key findings, and we found that I've put together the findings in one slide here to show that these findings were interconnected. We found that one finding had an Today I'm going to talk about some of the pre-existing vulnerabilities of these children, and Dr. Martin has already spoken or touched on some of these. And then I'll talk about how these vulnerabilities become more amplified adversities when the children that we spoke to were pregnant, and the role of systemic blind spots and the overlooked needs of pregnant children and how that impacted their pregnancy journey. Next slide, please. Speaking on the first finding, that is on pre-existing vulnerabilities, within this community, we found that a lot of children had grown up in intergenerational poverty, and they highlighted how their intergenerational poverty had placed them in risk for sexual vulnerability. And I know that a lot of research has focused on this, so I won't spend a lot of time on it, but I think that most interestingly, maybe to point out, somebody once asked us about the ages of the fathers, and I think it's also been put in the chat. The male partners were all above the age of 18. And I think someone will talk on a little bit later on about the complexities of culture and enforcing policy. But we found that with the children that we spoke to, whilst in the quantitative interviews, they highlighted that only 2.5 highlighted that they'd had transactional sex. Among the 18 children that we spoke to in the qualitative interviews, all of them highlighted, or when we spoke further with them and built rapport, since we had repeat interviews with them, they started to come out more that all of their relationships, in fact, had actually had a transactional component. But I think that we can all appreciate how sexual exploitation and transactional sex can be quite a layered discussion. And so I just think that's something that's worth pointing out. We found that a lot of the children, due to intergenerational poverty, a lot of even the grandmothers or the next of kin of the children we spoke to were themselves very young. We had grandmothers who were some mothers to some of the children who were part of the intervention who were as young as 26 or 32. And so this is something that was quite normalized in that area, and early marriages for children who were as young as 14 are quite common within that community and are often used as a response to pregnancy. So we found that household poverty as well was exacerbated by the lack of educational support that the children received. I think Dr. Martins has already shared that most of the children were already not in school by the time that they got pregnant. And a lot of children highlighted a lack of interest in school because they highlighted that they felt educationally inadequate, or that whilst education is considered to be a social protector for them, they felt like it wasn't a space. After they got pregnant, they felt like it wasn't a space that they could participate in. We also realized that a lot of the children highlighted, as already has been shared by Dr. Martin, that whilst they had had some level of knowledge on comprehensive sexual education, or they knew about sexual reproductive health technologies, we found that culture or patriarchal views of sexuality as a taboo, and the tabooness of that open parent-child discussion meant that for them, whilst they knew that the knowledge, the theoretic knowledge of comprehensive sexual education, they could not understand it on a more practical level. It remained very abstract to them because culture still acted as a mediator that inhibited or hindered some children's ability to access and actually apply on a more practical level the sexual reproductive health knowledge. Next slide, please. So this is just a running theme that we found across the accounts of a lot of the children who highlighted, for instance, here we have a 15-year-old child who highlighted how common it was in our community for intergenerational pregnancy cycles to happen within families. And she said that the community has gotten used to it because most teenage girls in my community are pregnant. That's just how it is. So this reiterates how early pregnancy is becoming a status quo in that community. Next slide, please. We also, I think this quote here, we thought it was important to add it because it shows something that we saw in a lot of accounts of the children, as has already been mentioned. Almost 80% had already dropped out of school by the time that they got pregnant. So this is a child who narrated a discussion that her parents had after she had gotten pregnant, where they were blaming each other. And she says that her mother said to the father, "Look at what the child has done. You are the one who used to say she shouldn't go to school." And her dad seems to nonchalantly reply and say, "Is it a crime for a child to spend her days at home?" And so this highlights the limited social protection through continued education that the children already had prior to getting pregnant. Next slide, please. And this leads to, you find that once already children existed with this precarious knowledge, of their household vulnerabilities. And so once they got pregnant, those vulnerabilities that they already were experiencing were magnified or heightened. For instance, we found a lot of children, once you get pregnant culturally, there is a shunning of children who get pregnant. And so most of them find themselves to be very lonely. A lot of the partners that the children had sex with were above the ages of 18. And because there is a policy that is it's supposed to be a crime, it's criminalized. We found that 91.7% of the children were actually deserted by their partners once they notified them that they gotten pregnant. And this is something that the children shared as well. The children also highlighted that they experienced a lot of bullying, not only within the community, but even in healthcare facilities, whilst they still were able to access care. In a lot of instances within the public health facilities, a lot of the children highlighted that they were not treated with respect because they were vilified for being pregnant at such an early age. We found as well that, I think someone spoke about this as well earlier on, that there was that heightened age-specific socioeconomic disadvantages, where we found that a lot of the young children, you find that because they dropped out of school early and because of their young age, they didn't have stable income or were unable to find income. And due to cultural norms as well, and also gender inequalities, we found that it was easier for they highlighted that it was easier for males within their communities to find jobs than for them as pregnant children. And yet when you become pregnant, these children get thrust into age inappropriate financial responsibilities, and it becomes their responsibility to take care of their own pregnancy needs as well as the baby. And so we found that this was something that heightened or the adversities that they were going through at that time when they were pregnant. On top of that, we found that families are also mediated a lot by cultural norms. Families expected pregnant children to bear the consequences of pregnancy through sometimes early cohabitation or forced early child marriage. So they were forced into situations where they needed to cohabit with the intimate partners if that opportunity was there. And so we find that with all this happening, most pregnant children reported suicidal ideation during pregnancy. They had high financial stresses, as they could not afford to foot the age inappropriate responsibilities that were thrust on them at such an early age. And this we found, just to reiterate what Dr. Martins had already spoken about, that most of the children had high symptoms of moderate to severe depression. Next slide, please. This quote, I think, just basically captures what I've already been speaking about the sudden adultification that pregnant and postpartum children in this context faced. For instance, a 15-year-old was reflecting back to when she was still pregnant, and she highlighted that she felt like adulthood happened suddenly to her. And she said, I wish I'd never gotten pregnant, because after getting pregnant, I was suddenly being treated like an adult. You'll still be a child lacking knowledge about how to navigate the path of looking for an income, and you'll be unaware of how to get jobs. And so this highlights the lack of safety nets within even families to protect children once they are pregnant. Next slide, please. And this slide as well here highlights the challenges that children face to meet their financial responsibilities that increase once they're pregnant, especially after being deserted by the fathers of the babies during pregnancy. Interestingly, in our community, they tend to refer to the fathers of these children as the owners of the pregnancy. So ownership for the pregnancy culturally is thrust upon or rather is put upon the shoulders of the male partner. But you find that once the male partner was not there, the children were left unprotected. For instance, here we found that a lot of children highlighted similar sentiments. For instance, the 15-year-old who was pregnant here said that the owner of the pregnancy, if he had been around, would have made it easier for me because he would have stood by me. Because if he was there, I wouldn't need to live with my mother. We would not have the stress of buying preparation. Next slide, please. And this slide just reiterates the aspect of suicide ideation, which is something that a lot of the children shared that they had contemplated after they'd gotten pregnant. And for instance, in this instance, a child highlights that she thought about drowning herself by a river that is close to the hospital. Next slide, please. On top of the lack of social safety nets, we found that there were quite a lot of systemic blind spots and overlooked needs of pregnant children, particularly when it came to the mental health care. Having expressed how the length or the need for mental health was really high, a lot of the healthcare workers and the counselors that we spoke to highlighted that they felt inadequately equipped or skilled to meet these needs. As a result of the system deficits in maybe enabling healthcare workers and counselors to meet these needs, we found that a lot of when even counselors that we interviewed were sharing how they deliver mental health to children who are pregnant, and even when the children were sharing their stories of how they had experienced counseling session or mental health delivery that we had referred them to, they highlighted that a lot of times there was stigmatizing language. And this is interesting because even the counselors themselves highlighted that they felt that when a child gets pregnant, it's a result of naughtiness. There's a word there that says muskanzwa, that is Shona. It's a Shona word that means naughtiness or mischief. And this word is commonly used to describe childhood pregnancy. And we found that this negative social norm was also reinforced within the counseling sessions, and the counselors actually highlighted that they themselves use these terms when referring to the children, even in the counseling session. And you find that this term really highlights that the vulnerabilities that thrust children into these precarious positions to begin with are often ignored by healthcare workers and are missing within, and they're not acknowledged rather within our system, and that can be a blind spot when delivering mental health care. We also found something that was quite interesting was that when conducting counseling, the counseling approach was not the typical open-ended psychological counseling that you would expect, for instance, in therapy. We found that the approaches were more prescriptive. They told the children what they needed to do. So they were more like fixed assessments rather than open-ended counseling. And as a result, we found that there was low repeat engagement with counseling services. And a lot of children highlighted that they didn't feel like they could trust the providers. We also found that the interventions that were available, whilst limited because of the context, the low resource context, the few interventions that are available and adequate to meet the long-term needs or to meet the complex mental health needs of pregnant children, because they tend to be more crisis-focused interventions where counselors focus on prevention for suicide particularly. And it was a needs-based response and not necessarily due to training. And so that we found that these were some systemic blind spots that children have to overcome or come up against once they're pregnant and are seeking care from the system. Next slide, please. So just in closing, I wanted to just highlight using this slide that whilst children who get pregnant face a lot of isolation and mental health risks, all these things are happening.
Sorry, I think we've lost our speaker. I think she may have just dropped out. I'll just see if she's able to come back on. Thank you for your patience.
Super. While we wait for Nodi to come back, what we'll do is we'll probably make a start on the questions, or if there's if Svetlana wants to join, that would be fine.
Thank you very much. I think if Noni unfortunately dropped out, maybe I think it was one of her closing slides, so maybe Kevin can move on to my part of the presentation.
That would be great. Thank you so much, Dr. Austin.
Okay, well, thank you so much for this wonderful opportunity to talk. And my part really is going to focus on discussion and why is the situation as bad as it is for Zimbabwe, and where can we find the opportunities to improve it? So next slide, please. So just wanted to give a little bit of a background about Zimbabwe. Maybe not all of us know it as well as we do who live and work here. So we have a very young population. So 41% of our population is younger than 15 years of age, and 2/3 are younger than 25 years of age. So, and when we separate that group of 10 to 19-year-olds, that high-risk group that we're talking about today, that constitutes almost a quarter of all the population. So it's not small numbers that we're talking, and they're the ones that are neglected by policies as well and by our healthcare service. There's lots of cultural and religious beliefs and practices that shape relationships in our country. There's a patriarchal practices, and they all result in gender inequality. So women in general have a lot less rights than men. They have limited access to services, including education, healthcare, social protection services, and family planning comes into it as well. There's a very high rate of gender-based violence in our country, and about 40% of women at some point have been subjected to gender-based violence. It's a very fine line, even in children, what you call discipline in our country and what you call child abuse. So those are the problems in terms of our cultural beliefs. Economically, it's not a stable country. We have a poor performance of our economy that puts challenges in service provision, and particularly we're talking about healthcare provision here. There's a limited access to social services as well. For example, under 5 years of age, children are supposed to get free access to medical care, but that's not always the case. And that service is not universally provided across the country as well. Our healthcare system, we have very heavy dependence on non-governmental organizations, and that's difficult because that means that we cannot budget, we cannot plan, and sometimes the care provision in certain areas is inconsistent. There's also challenges in staff training and nutrition. Lots of our health workers immigrate to other countries as soon as they're trained and have the opportunity to do so. So training and continuity of care becomes a problem. We face many resource limitations because of other things that I've mentioned above, and the user fees are often quite high and unattainable for our population too. Next slide. So I'm just going to talk about family planning in Zimbabwe. So unfortunately, funding for contraceptives remained reliant on donors, as I mentioned in the previous slide as well. So stockouts are very common. Nationally in the country, there's about 10% of unmet need for family planning services. And as mentioned before, we have high rates of adolescent pregnancies. Nationally, it's about 24.1%. And it's hardly surprising when I referred to what the proportion of population that age group constitutes. And of note, there's also disproportionately high rates of adolescent pregnancies in rural areas versus urban areas. It's only almost a double. And that's also to do with some cultural practices that I'm going to mention a bit later on in my discussion. And there's a huge gap in contraceptive use amongst adolescents. So as you heard from the presentation from Kevin, very few of them actually used any forms of contraception at the time that those children got pregnant. Next slide. Yes, we have some very good policies. Some of them are listed here. The main one is Zimbabwe National Family Planning Strategy 22-26, and they all state, and the rest of them that are listed in there, and they all state that adolescents and young people should have access to family planning services and sexual reproductive health services as well. But in practice, the implementation is very difficult. And it's because we have very confusing conflicts between the culture, the law, and the policies as well. So on paper, we have very good policies that's supposed to protect young people and supposed to take care of them in terms of their reproductive health. We also have educational policy that states that sexual education has to be delivered at schools, but unfortunately, most of the time, it consists that the only contraceptive tool is the abstinence. So it's very much of a taboo as well, and that attitude is perpetuated by parents at homes as well. Next slide. So some of the strategies that outline in those policies, those are our goals. So improving knowledge and attitudes towards adolescents' use of sexual reproductive health services amongst decision makers, partners, caregivers, and community leadership as well. So we are here talking about traditional leaders. Improving attitudes and practices that enable adolescents to access and utilize family planning services. We aim to strengthen the capacity of teachers to carry out comprehensive sexual education at schools. And then big sweeping statements about implementation of a comprehensive social and behavioral change strategy targeting parents. All those sound very good on paper, but implementation is very challenging. Next slide. And this is one of the reasons is that our law is actually very prohibitive. So in the beginning of this year, our president stated that consent for sexual relation was raised from 16 to 18 years of age, and that was to align it with the age of the minimum age of marriage. So that means that if there's a sexual relation in anybody below 18 years, it's a criminal offense. They talk also about possibility of waiver if the age difference between partners is less than 3 years. So a very prohibitive law, but then again, there's a waiver, so nobody is actually quite sure. But this is what was agreed on this year. Next slide. So this law that comes from big offices in Harare, that's what then clashes with our cultural practices. And if you go somewhere in Chikobedzi and deep rural areas, actually the cultural aspect there is very strong. They still have the rite of passage ceremonies. So, for example, when a girl starts menstruating, then she introduced to the ceremony of the rite of passage, when she goes through a special process of sex education, and then she's sort of given like a grade. So it's in some of the communities they wear brightly colored hats, and then that hat collects pins, depending on how well she's done in her rite of passage ceremony. So, and you can imagine this girl could be as young as 10 or 11 years of age. And that really does not align with the law that's coming from the big offices. There's taboo on adolescent sexuality. So, like I was mentioning, the only way the contraception is approached, it's abstinence only. And there's lots of myth about contraceptives as well. For example, there's a belief that if contraception is used before the first pregnancy, it causes infertility. So again, it seems like for adolescent girl, it's very difficult to access family planning services. But if you become pregnant, even if you're age 12, suddenly you're offered long-term contraceptives, and any option of future contraceptions is available for you. It's almost like you need to become pregnant to be able to access contraception going forward. And again, something that Noni already mentioned about forced child marriages. So you've got communities that are very strict, and you've got the communities that's really have deep-seated culture about early child marriages and rite of passage ceremonies. So it creates a conflict, and it makes it very difficult for health service provision, because on paper and on policy, the service is supposed to be offered to adolescents, and then you have law on one side and cultural practices on the other side. Next slide, please. So what are the recommendations that we came up with as a result of the study? So on a policy level, really need a clear framework to effectively operationalize the guidelines on integration, family planning and sexual reproductive health services, HIV and AIDS into adolescents' healthcare services, and really need to ensure engagement of all relevant stakeholders to improve knowledge and attitudes towards adolescents' use of family planning and reproductive services. Next slide. For medical care, we really have to improve access to family planning services for adolescents, whether it's child-friendly corners, but something that's we really need to educate our healthcare professionals as how to effectively deliver the services to young people. They should be designated and accessible antenatal and postnatal services that are tailored for children's needs. We have to strengthen linkages and referral pathways for all pregnant children in need. It has to be a one-stop shop where they refer to all the appropriate services. We need to be better in offering long-active contraceptives postpartum. Of notice that I think pretty much all of our participants agree to long-term contraceptives postpartum as well. So it's all about giving them the opportunity. And then we're also talking about education outreach to households to support optimal infant care. Remember, those are children that now have their own children. So really, myself as a pediatrician, my main concern was what happens to those little babies that born to 14, 13-year-olds who also can't really care for them and don't have the knowledge or the means. Next slide. Noni talked a lot about mental health, but really we need to provide training of relevant primary healthcare personnel on early identification of mental health problems. So it's not crisis management approach, so we can focus on prevention in these pregnant children. We need to make sure that active screening is done and vulnerabilities are addressed to the best of our ability. We need to provide inclusive environments, and we need to adapt these existing systems. We mentioned the friendship bench, and really it's not designed for young adolescents. And the trainers themselves, as Noni was saying, they often perpetuate the stigma and worsen the situation on the ground as well. So we need something that's tailored specifically for these young people. And then we have to have a clear referral pathway for higher level care. Yes, those pathways exist, but they're seldomly used, sometimes because of lack of knowledge of their existence. And we have to come up with the specific psychotherapeutic interventions for postpartum children because their needs are very specific and very unique. Next slide. For educational system, we need to work on involving relevant stakeholders to develop a strategy of reducing school dropout rates in vulnerable communities. We heard about that majority of these children were out of school at the time they got pregnant. So then we think that school and being in school is protective. And then in terms of sexual education, how are we going to teach those children if they're not in school in the first place? How do we reach those children that stay at home? We talked about evaluating existing educational social welfare policies to ensure inclusive support for pregnant children in practice, so that if they want to rejoin the school, they have the opportunity to do so. Majority of them, however, as came out from our study, actually were more interested in vocational training, because the expectations, as Noni was saying, that now they're expected to be main earners and provide for their needs and needs for their baby. Next slide, please. So what have we done so far? So we went to the Ministry of Health and other relevant ministry officials with our findings to make them aware. Then we also went to Epworth and we presented to staff of the Epworth clinics again on our findings and got their feedback on the results as well. And also we initiated a national dialogue, including stakeholders from both government and non-governmental organizations on how we can plan the way forward in this very complex environment. And some of the stakeholders are displayed there. Next slide, please. So those are my references. And next slide, please. We just wanted to acknowledge our participants and thank the brave children who shared their stories with us. Their insights and experiences were really invaluable. And our goal is for this research to translate into tangible and meaningful changes that improve the lives of vulnerable pregnant children in our country. And our special thanks go to all research participants, Ministry of Health and Childcare, and all the stakeholders in Epworth and other partners as well. Thank you very much.
Thank you so very much. Wow. Through Zim Team, you do a fantastic amount of work. That was great. Thank you for such a detailed presentation and really, really interesting things that you're involved with. Sadly, time is not our friend today by the looks of it, so we are really struggling. Wondered whether, there were a couple of questions in the chat, which I wondered whether you wouldn't mind having a little look at and answering. And there's one for Sifa as well in there, if that's okay. And what we might have to do is take a 5-minute comfort break and then come back for Dr. Anshu Banerjee's talk, if that's at all possible. If there are any further questions that pop up, we're very happy to forward them to you, if that's okay. But we are so grateful for all the work. And as many people have said, the terminology that you're using around pregnant children really hits hard. That really focuses on mind. So thank you for sharing that with us. Daniela, was there anything that you'd like to add?
No, not really. Just thank you so much for your time and thank you for shedding light on an area that we probably don't focus too much on, and also just seeing the link between gender inequality and health care, and the importance of cultural, realizing cultural difficulties, cultural barriers, and cultural practices, how that can affect and make it really difficult to engage with communities on these issues. So thank you for everything.
Thank you. What we're going to do now is we have a total of 7 to 8 minutes for a very brief stand up, grab a drink break, and then please do come back, as Dr. Anshu Banerjee will be here to share with us, and he's a special, a very important guest from the World Health Organization. Thank you very much. See you soon.
Welcome back, everybody. Hopefully you had a chance to have a short break. And I apologise for the slight delay with the timetable, but as I'm sure you all agree, it's been an absolutely packed day with so many high quality talks. And it's really been a privilege to listen to all of the high quality talks, the speakers, and a lot of the discussion has also been excellent. So we've been thinking about Sustainable Development Goals, about the next 5 years. We've also been thinking about some of the intersectionality around gender, childhood disability, hunger, and how these things might impact the SDGs. So we are absolutely delighted to welcome our final keynote speaker, who is Dr. Anshu Banerjee, who will give a closing talk and really finish off the day. So Dr. Banerjee is the Director of the Department of Maternal, Newborn, Child and Adolescent Health and Aging at the WHO. He's over 30 years experience working in this field and also has a strong history of working with United Nations, MSF, DFID and Gavi earlier in his career. We're delighted to have you with us, Anshu, and I hand over to you if you'd like to.
Thank you, Helen. I hope you can hear me.
Yes.
Yes.
Okay. Thank you.
And let me try to share the slides. I hope I remember from yesterday how to do that. And if all is well, you should now see a full screen?
Yes, we see a full screen.
Thank you. Yeah. Thank you very much, first of all, for the invite and for inviting Dr. Tedros, in fact, to give the remarks. But he's traveling, and so it's a pleasure for me to represent WHO in this webinar today. And it's a pleasure to be with everyone here at the International Child Health Group and this particular winter session. And I'll sort of present a little bit what is happening within WHO within this area of child health, and maybe I might be repeating a little bit what has been presented earlier today. I was not able to join, but I'll not go too much through statistics. I understand Joy did a lot on the epidemiology in the morning, and so I'll be talking a little bit more about what's happening with WHO. So maybe a bit of recap, but just to highlight that we still have 4.9 million children dying under the age of 5. 47% of those die within the first month of life, and the remaining 53% die during the following 59 months. The global level of under 5 mortality, however, masks substantial variation between countries and regions, and here you see a couple of those statistics. And you'll, of course, see on the map where mortality is highest. In 2022, a country level under 5 mortality ranged from 1.5 deaths per 1,000 live births to 117 per 1,000 live births. So huge discrepancy there between different countries. And at the same time, the newborn mortality ranged from 1 death per 1,000 live births to 39 deaths per 1,000 live births in a couple of countries. So huge discrepancies globally between the mortality rates. But also, of course, we know that there are in-country discrepancies as well, or inequities that need to be addressed. Looking at where most of these deaths happen, mainly Sub-Saharan Africa and Southern Asia, we also know that 4 out of 5 deaths actually occur in these two regions, more or less. So with the declines in mortality plateauing, looking at, are we achieving the SDGs or not? 59 countries currently are at risk of missing the Sustainable Development Goals under 5 mortality target. And the ones that actually are still above 100 are Chad, Sierra Leone, Somalia, Nigeria, and Niger. So still a lot of countries that have very high child mortality. And we have 64 countries that are at risk of missing the neonatal mortality target for the Sustainable Development Goals. And in many countries and many regions, the rate of reduction has reduced, and the acceleration needed to achieve the Sustainable Development Goals is multiple times the current rate of reduction. So the map again, and here mainly looking at Africa, but also a little bit at South Asia. You can see that the darker the color is, the higher the acceleration needs to be, or compared to the current acceleration, how many times more it should be. And so in sub-Saharan Africa, the countries that are red, let's say, the acceleration in order to achieve the Sustainable Development Goals needs to be 5 times more, at least 5 times more than what their current rate of decline is. And so this is, of course, very worrying. We know that on the maternal mortality side, for example, in a number of countries, this even goes up to 10 times. So then looking at the causes of mortality for children under 5 and how that is different between regions, but also how it has shifted between 2000 and 2021. So when we look at, when we look at causes of mortality for children under 5, we see that preterm birth and interpartum complications did not really change over the last 20 years by region, while infectious diseases such as diarrhea and pneumonia are having a decreasing proportion of deaths for children under 5 in most regions. And at the same time, we see that congenital anomalies are in an increasing proportion of deaths under 5. So just looking at this, and I suppose that a lot of this has already been discussed earlier in the day, but continuation of business as usual will mean that we will fail to achieve the Sustainable Development Goals and other global targets, and we should be looking at sort of, potentially new tools, new technologies to also help reverse the decline in progress towards the Sustainable Development Goals. And I'll just highlight a few of those examples that we've been working on and also that are happening outside WHO to give a sense of, what could be ways to sort of leapfrog a little bit the decline in the stagnation in decline in mortality rates. So one piece of work is what we call the risk differentiated care and how this could be a paradigm shift to improve child mortality. And what we did is we looked at data and what are the age-specific absolute mortality risks that are associated with the anthropometric deficit, with being born small, whether preterm or small for gestational age, and looking also at low birth weight, and also looking at the history of breastfeeding. And so we were looking at what the age-specific mortality risks are when individual exposures are combined. So we looked at 33 studies that included over 75,000 children and had around 550,000 observations. And the absolute risk of death per 1,000 child months was highest in the first month of life and continued to be elevated until around 24 months. And thereafter, it was sort of low and relatively constant across the age groups. However, for children with a weight for age score of less than 3, the risk of death increased to almost 20 per 1,000 child months. So a huge additional risk factor there. And similarly, looking at low birth weight and reported premature birth, that increased the risk of death during the first year of life. However, when no breastfeeding, low birth weight, or preterm birth were combined with weight for age of less than -2, the risk of death increased substantially, going beyond 30 per 1,000 life months per preterm birth, or going beyond 30 per 1,000 life months for preterm birth specifically. So this combination of the risk factors, let's say, is really increasing the risk for death. So these findings allow us to introduce the concept of risk assessment of individual children and to reframe our approach from a disease perspective, when we looked at, for example, IMCI and treating children for specific diseases, to a more child-centered perspective. And it helps us and it guides us to think about providing care not only for the presenting illness, including its severity, but also in relation to the underlying risk of the child and whether it is high or low. So, for example, currently we are managing a 9-month-old infant with a history of low birth weight, not breastfeeding, and who is low weight for age and presenting with diarrhea and dehydration, exactly in the same way as we would treat a 3-year child with normal birth weight, with a history of breastfeeding, with normal weight for age, and also presenting with diarrhea and dehydration. And so this issue of risk stratification should really help us think through how we can better address the underlying risk factors for the child. And so this would be a more child-centered approach rather than a disease-focused approach, and will allow us to look at prevention as well as treatment. So from the prevention perspective, identification of low birth weight or prematurity at birth will allow us to ensure intensified follow-up through well-child visits. And when it comes to management, it should also guide the immediate treatment and referral as well as follow-up care. So that is one area that we sort of looked at. The other area, as I highlighted, that the proportion of under 5 mortality due to birth defects is increasing. And at the moment, it's almost 10% of under 5 mortality overall, and it's almost 30% in low mortality settings. We're thinking of developing, we're actually in the process of developing a framework for countries to plan and implement newborn screening, diagnosis, and management in order to support Ministry of Health program managers in low and middle income countries to prepare the health system to embed routine screening services and pathways to diagnosis and management. And we'll, of course, also look at the prevention component after that. The framework will therefore not focus on one or another particular condition, because different countries might want to focus on low-hanging fruits, or depending on what kind of advocacy is happening in that country on a particular condition. But it would allow countries to choose which conditions they would like to focus on initially, and then building on that, add on other birth defects for screening and slowly build up their program. I think everyone is aware of the IMCI, and this was developed together with WHO and UNICEF. And we had a review, I think in 2015 or 2016, to look at, where are we with IMCI? Is it still relevant? And what would be sort of the way forward? And coming out of that consultation, we looked at what are the current trends towards a new agenda of child and adolescent health and well-being. And so what we basically looked at was changes in mortality reduction. And we thought that it was time to start not only focusing on survival, but to move towards also the thrive and the transform agenda. It was also important to see that, there was a shift in pattern of mortality and morbidity, the causes of mortality and morbidity. It was also, we saw that social determinants are still are just as important as biological factors. and that there is a need to ensure that the continuum of care is provided, and that we also have resilience within the health system. So besides moving towards also a Thrive agenda, it looked at the whole continuum and to move away from, let's say, the child under 5 to starting with preconception care all the way up to the age of 20, looking at multisectoral action because of the social determinants of health, but also looking at a shift from only looking at coverage to improving quality as well, and to go beyond, let's say, programmatic interventions, but to also look at the health system in general. And as a result of that, we came up with a guidance document on a framework for well-child visits, and I think earlier this year we launched the guidance on scheduled well-care visits, which was basically looking at the rationale for objectives to have well-care visits. We looked at all the different recommendations coming out of different guidelines by WHO, and thought that there was enough evidence to propose a minimum of 17 scheduled visits from 0 to 19 years. It provides guidance on actions and expected tasks during these visits. It also looks at identification, support, and timely referral, as well as outlines actions that providers can take to maximize opportunities and resources. And so, looking at what could be the objectives of the well-care visits, it was looking at disease prevention, whether primary or secondary prevention, looking at health promotion, looking at problem identification, as well as anticipatory guidance in order to, when parents and the child come to a well-child visit, to sort of explain, what they can expect over the coming period before they come for the next visit, and how they can be prepared for that. The well-child visits, and of course they're happening already in a number of countries, but particularly in high-income countries, provide. But the idea is that how do we introduce this into a low and middle-income country setting? But these care visits would provide opportunities to promote health and healthy behavior, observe progress of child development, whether mental or physical. Of course, looking also at interventions that can be provided, such as vaccination or supplementation with micronutrients, but also looking at their health risks, delays, and disabilities, and identify those and address the needs that they have, but not only of the child, but also of the caregiver. And here you'll see sort of the 17 visits that we outlined, very much in the under 5 age group, let's say, following the immunization schedule. So besides the routine postnatal care visits, the 3 postnatal care visits would follow the sort of immunization schedule. In a number of countries now, they're introducing the malaria vaccine at 6 months. And then looking at annual reviews from the year of 2 onwards. For school-going children at primary school, we thought that we could have 2 visits, and for adolescents also 1 during earlier and later adolescence, in order to look at particularly what their risk factors are, etc. So basically, it's a comprehensive approach whereby the different concerns from both the parents as well as the child or the adolescent can be addressed. It could be medical, it could be psychosocial, it could be environmental. It would include physical examination, but also looking at growth and development, and screening where relevant, etc. So maybe coming to so this is the well child visit, and of course we hope that children, grow and improve properly. But of course they can be sick, and then they will have to go for treatment. Pneumonia is still one of the biggest killers for children under 5, and so we were wondering, what could be some of the innovations in order to improve the diagnosis for pneumonia. And currently it's based on 2 clinical signs: fast breathing with respiratory rate that is with age-specific cutoffs. And also the second sign is lower chest wall indrawing. And in order to improve the management, better diagnosis is needed. And for pneumonia, one of the key issues is to be able to distinguish between a bacterial and a viral pneumonia, and identify children who actually do not need to be treated with antibiotics. At the moment, the guidance is that all these children will need antibiotics or are given antibiotics while many will not need it. And so some of the innovations that could help improve the diagnosis could be lung ultrasound, digital stethoscopes, and cough sound algorithms, as well as biomarkers. And even though there are some innovations out there, the accuracy is not yet really proven, and so still work in progress. And at the same time, people could also look at scores. And so here are a number of scores that have been tried out, but except for the WHO Prepare one that has been tested, most of these scores have actually not been validated. And so that would be something else that would be important in order to, based on the score, also be able to diagnose pneumonia in a better way. Other things that are, let's say, coming up and are sort of targeting individual risk could be, for example, targeting the most vulnerable during pregnancy. And this would require, and this would help to date all pregnancies. And also another issue that's very important is to weigh all newborns. So we know that there is AI-assisted ultrasound-based gestational assessment that is quite simple, accurate, and relatively low cost. And with handheld machines, this could become a point-of-care intervention, so that community health workers, community midwives could do this even during a home visit, let's say, and have a much more reliable estimate of gestational age and potential other issues. Similarly, for growth monitoring, there's been AI-assisted anthropometry and developed that could allow growth monitoring with mobile phones. And that could potentially also provide a powerful tool to support what we spoke about earlier, the risk stratified or risk differentiated care. Looking at other innovations, so here we have point of care diagnostic tests. And that could be, for example, detecting single microbes that could detect single microbes to wider arrays. So to move away from just single, but to a wider array. And they could be, and we could also have point of care tests for CRP. And so it would be desirable to have those as well, for example, for testing antimicrobial resistance. And that could be, very powerful when linked with AI-assisted algorithmic diagnostics. Coming back again to the risk stratified approach and how this could lead to better follow-up care. Here's an example of what has been implemented in Uganda, where risk assessment resulted in more individualized care and follow-up, supported with SMS reminders and back referrals to reduce post-discharge mortality. So this is already being tried out, and very encouraging that people are already thinking of how to use this in practice. We also have research ongoing to try to intervene earlier, for example, to prevent preterm birth by reducing inflammation, by administering a novel allosteric anti-inflammatory peptide, which has shown positive results in mice and with human studies in the pipeline. So again, innovations that are in the pipeline. And WHO is also currently conducting a trial to see whether probiotics will improve the microbiome and reduce neonatal mortality. So, for example, the growth of Bifidobacterium longum and particularly the subspecies infectious has a linear response to breast milk. And so the more the newborn is breastfed, the more it will multiply. And the trial also that we're conducting will establish the baseline of the newborn's microbiome. So one can evaluate at the end which children benefited most from the microbiome, let's say, or which children with which microbiome benefited most from the intervention. And speaking of the microbiome, we know that breastfeeding, of course, is a key factor in promoting optimal child development through microbiome management, as it promotes a diverse range of beneficial bacteria. And so always, an opportunity to highlight that breastfeeding is best unless it's really not possible. So next, I wanted to come to what we call a digital adaptation kit for child health in humanitarian emergencies that we have developed, and wanted to highlight this because looking at achieving the Sustainable Development Goals, we know that around 50% of mortality, whether it's maternal, newborn, or child mortality, takes place in humanitarian settings. And so how can we support practitioners in humanitarian settings to provide optimal care? And so for that reason, we adjusted or we used the IMCI algorithms, and we, based on that, developed a digital adaptation kit for child health that people can download and can use. So the process was really looking at what are the current recommended interventions based on WHO guidance, looking at what are the essential interventions performed by different health cadres, looking at how they could use a digital system in order to support their practice, let's say. And then we developed generic workflows representing clinical and non-clinical processes, because when you adapt this into an IT system, let's say, you have to, when you have a flow chart that you just use on paper as a clinician, you will already have a lot of assumptions that you follow, let's say, as you're following the flow chart. But when it is IT that does that, you have to actually make sure that all those other assumptions are included. And so it's quite some work actually to turn it into an IT tool. And then we looked at, how can we use this for decision making? And finally, we looked at, how to actually implement this from a digital perspective. So scenarios for use. This has been piloted in one country, and we're hopefully soon going to pilot it in another country. But some of the things to keep in mind is, what is the digital system that you already have at the country? Do you need to establish that? And how do you then update existing paper registers in order to move towards a much more digital system? So it's got an app version as well. and we hope that these will be used in emergency situations. Now, another point about how to support, let's say, the area of child health. We know that still in many countries civil registration is not yet fully in place, and so there are innovations there again that could help with that. So we could have phone apps that are used, and with high coverage globally, it should be possible to have much higher coverage of vital statistics recording, because in view of not only in having the estimate of during pregnancy, but also ensuring that we know when the child is born, will help us really in moving forward with applying the right kind of treatment, etc. So making sure that every child's birth is registered is very important. And maybe I'll just highlight a few slides. My last few slides are around the research that we're doing. At the moment, WHO has been involved in conducting a number of multi-country trials, and this has been important to support guidance and not only guidelines, but also guidance for countries, and helped us also identify how to scale up interventions, etc. And so we're looking at questions on implementation, the ideal implementation, but also looking at innovations and identifying what could be critical evidence gaps. So one of the things is that, what should WHO take forward, and what should other research institutions take forward, and is there a comparative advantage for WHO to conduct research? So we're looking at sort of three different scenarios. The first one is WHO sponsored to conduct research, and the research that we've been doing has been very often multi-country, multi-center, and also looking at questions that sometimes other research institutes wouldn't look into. We could also, let's say, just look at see how WHO can be engaged in monitoring the research. And finally, we could also look at, can we be a facilitator and be a partner in the research while we actually don't conduct the research ourselves? So there were three kind of models that we were looking at. And so the direction that we're thinking of at the moment is maybe more to be a kind of partner, facilitator of the research, whereby we can be involved in sort of defining what the research question is, identify potential funders and institutions that could actually conduct the research, be a partner in the protocol design, as well as the design for the SOPs and the CRFs, but also be involved in training and monitor the trial, as well as provide data management and provide an open access data repository, and as well as for metadata. So let me stop there, and thank you very much.
Thank you so much, Dr. Banerjee. That was absolutely wonderful. I've been furiously taking notes and scribbling things down, because so much of what you touched on was already mentioned by speakers earlier in the day, and that just brought it together really nicely. So this morning, Professor Joy Lawn was talking about optimism, pessimism, or activism with regards to the SDGs. And I must say, after your talk, I'm feeling incredibly optimistic that through innovation, child-centered care, and a different approach, that we can make rapid progress in the next 5 years. So thank you very much. We have some questions, and we do have time to take them as well. So from Rebecca Searle, who's a PhD student in Liverpool, amazing work. Great to hear of the exciting and important developments that WHO are working on. Great to see the paradigm shift and increased emphasis on the whole CYP and collaborative approach. Given the complex and varied systems involved in health, education, social care, and wider determinants of health, how do you suggest that we best build these collaborations to improve the well-being of the child? So how do we collaborate intersectorally?
Yeah, intersectoral collaboration has always been a difficult issue, I think, particularly when we look at, for example, nurturing care for the child, etc. We have started. We've done a couple of pilots with a number of countries in looking at early childhood development and how to bring in other sectors. For the nurturing care approach for children up to 3 years, we felt that that domain was still very much focused on the health sector. But once children become older, then the education sector becomes important, etc. Of course, a lot of collaboration is needed with the WASH sector in order to ensure that there is running water in the community, but also in health facilities. Unfortunately, we still have around, in low-income countries, around 50% of facilities that don't have running water. And I was just on a call recently where even in a NICU, let's say, in a tertiary level hospital with an intensive care unit, they didn't have running water. So intersectoral collaboration is very important. Now also looking at parenting skills and support from the social sector when you talk about children with disabilities. How do you do that is another area. What we've done recently in Malawi is that we engaged with the Ministry of Health to look at how they thought that they could actually take the well child approach forward. And they said, when we look at our policies, a lot of this is already existing in our policies. And very often a lot is also existing in plans, but how do you actually implement it? So what they wanted to do was to really look at what they have in their policies, what's the health workforce that they have, because many of the low and middle income countries, well, even high income countries, we don't have sufficient number of healthcare workers. But particularly in low income countries, let's say, we don't have enough healthcare workers. So how can you then develop a well child approach, looking at the health workforce that you have? And that is one of the things that Malawi is doing. They're looking at, we have, a lot of these things, we have them in our policies. We would like to implement it. We would like to have a well child approach to child development. And at the same time, looking at the health workforce they have, how can they actually materialize that? So that's work that we are initiating at the moment, and we hope to learn from other countries as well. At the same time, we're also trying to do a stock take with all our regional offices, because we know that in a number of countries, this approach is already moving forward. For example, in our Eastern Mediterranean region, Egypt is looking at a well child approach. In our Western Pacific region, we have Laos and Cambodia, I think, that are taking that approach. So there are things that we should be able to learn already from countries and share it between countries to take that forward. And particularly that intersectoral collaboration is something that we really need to learn more about.
Great. Thank you very much for that answer. That's very informative. We've got a few more questions in the chat. Just following on from what you were saying there, Andrew Tompkins has asked, what are the highest priorities among your suggestions as far as LMIC, Ministry of Health, are concerned? So what's important to the MOHs?
So I think we're still struggling very much also with the Survive agenda. And I think what we feel is that by the well child visits, let's say, we can also address mortality because it addresses both the mortality risks as well as morbidity risks. And so that Thrive approach should help that. But when it comes to newborn mortality, for example, at the moment, we feel that it's going to be useful for countries to really invest in second-level special care units for newborns. A lot of that mortality cannot be managed in the community or primary healthcare level. These children need to be referred to units where they can get the appropriate care, whether it's because of the medicines they need or the interventions they need, etc. So that's on the newborn side. On the post-newborn, so the 1 to 59 months, we know that the major causes are still pneumonia, diarrhea, malaria, and very much linked to malnutrition. So there, I think this approach of the risk stratified approach, looking at what are the risk factors that these children have and how can we address that earlier on so that we address those risk factors before they fall ill and then have high post-discharge mortality or high mortality after treatment for the illness. How to see how we can address that earlier on and really look at addressing these things at the community level.
Sure.
So that would be malnutrition, ensuring there's wash in the community, etc., etc.
Sure, and you can imagine that innovations are really going to be key to that, especially at secondary health centre level.
Yeah.
Sure. Thank you. So we have a question about the WellCare visits. How can we ensure all children in LMICs have access to the WellCare visits, as not all of them will be on the national register?
So this is one of the let's say challenges that we have, I think, when it comes to child health, because we've been working recently to really see how we can support countries in strengthening their child health programs, and the child here being defined as 1 to 59 months, so not the newborns, but how do we strengthen the child health component for those children? And there, the biggest causes of mortality are still malaria, diarrhea, and pneumonia, and so when we looked at, for example, but what can we set as a target for children under 5? Is there anything that we can measure? It was challenging. It's not always easy to, for example, know whether the families sought care for a child with fever in the last 2 weeks, or those kind of indicators that we have in surveys, but are more difficult to measure in routine health information systems. And it are the routine health information systems that allow, let's say, national programs to react more quickly to what is happening on the ground. And so we hope that as countries will start introducing these well-child visits, that the coverage, just like you have immunization coverage and that a child come for immunization, that we could look at coverage of well-child visits and do parents and their children come to these visits, and that would help us, let's say, have a better understanding of services provided to parents and children.
Great, thank you. And that in time the coverage would increase. We also have a question here around opportunities for paediatric trainees, UK-based paediatric trainees or from other parts of the world, to become involved in any of the work of the WHO.
Yes, WHO has opportunities through internships. They're not many though, I mean, you can always reach out. Often we have to do systematic reviews and things like that, and we have had collaboration with, for example, LSE, where LSE, I think, has a program that during their trimester they have teams of 4 students who have to look at a particular question. And we've done that over the last couple of years, whereby we have teams, we present a question And if interesting to a group of students, they engage in that, they do the reviews, they come up with next steps, etc., and they present that back to WHO. So there are ways, let's say, for institutions to collaborate with WHO through these kind of collaborative efforts, let's say.
Great, that's really good to know. And on that note, if for any researchers in the audience who are wanting to partner with WHO on a particular research grant or program grant, what is the process for organising that?
Reach out to us, and we will. It will most likely be on a case-by-case basis. So, but please feel free to reach out, and would be more than happy to engage.
Great. Through the regional offices, or?
It's for research. Research is conducted mainly by us at the global level, of course, with the support of our regional offices and country offices, and we identify jointly, let's say, the institutions at country level that will be involved. If you are a research institute in a low-income country, you can reach out to the WHO country office, but you can also reach out to us, and we can have a conversation.
Thank you. Thank you so much. And there is one final question, and then we will wrap up. So it's regarding reducing prematurity. Do you think we need to be looking at more holistic bundles, multiple antenatal interventions? What are your thoughts around how to reduce prematurity? That is a huge question.
Yeah, I think once we know that the individual intervention is working, then I think we could think through about bundles. We've seen in many, just looking at, for example, postpartum hemorrhage, where we did the emotive trial by our colleagues in the SRH department. We noticed that, the individual interventions, if you do them all at the same time, it has a tremendous impact on mortality reduction. And for other interventions, this has been shown as well. So the bundle approach, I think, is an established concept. So I would say, yes, it would be good to have a bundled approach to addressing, including to address prematurity. Whether a trial could be helpful for that, yes, I would think so in a real life setting. So it would really be implementation research, I think, to look at a real life setting and see whether bundling it has a better outcome than maybe staggering individual interventions.
It sounds like your inbox may be very full after this talk with lots of ideas. So on behalf of the committee and the audience, I'd like to sincerely thank you for your time and for joining us today. Thank you.
Thank you. It's been a pleasure.
So I will now hand over to Becky, who will share a video and a tribute. Thank you.
Thank you very much. We've had an amazing day, but on behalf of the organising committee of the conference, I'd like to take a few minutes to pay respects to a very treasured colleague known to many of us in the global child health world, who, when we started planning this meeting many months ago, did kindly agree to give us a plenary talk focusing on Sustainable Development Goals, climate change and infectious diseases. Dr. Pu Ying Irotam was an inspirational lady and an emerging leader in the area of infectious diseases. Many of you will know her from her time as a senior clinical lecturer at the Liverpool School of Tropical Medicine in the UK. Just last year, she joined the International Centre for Diarrhoea Disease Research in Bangladesh, ICHG, and we were very sad and shocked to hear of her death in September. And it's with sadness and care that we therefore share this tribute slide from one of her colleagues in Dhaka in Bangladesh, and also a video that they sent to us to share with you. I'm going to stop sharing this, and hopefully Daniela will share the video for us.
So I'm so thrilled to join ICHG. I'm someone who I think brings with me this global experience. As someone who grew up in East Asia, was educated and trained in North America and Europe, and then spent the last 8 years working in Africa. I was inspired to join, to learn about infectious diseases and global child health through a desire to really make an impact during my time here on this earth. And when I think of ICDDRB, there are two words that come to mind. The first is excellence, and the next is impact. And when you think about what ICDDRB has been able to achieve over the last several decades in the area of both global child health and infectious diseases, I mean, they've developed oral rehydration solutions, they've combated or managed severe malnutrition. These are issues I dealt with on a daily basis as a clinician in Africa, and we use those same techniques. So I think it's really had a wide-ranging impact on many parts of the global south. Now, when I think about what are the key infectious diseases that are affecting us today, I think we've been most recently been hearing about Mpox, and then also COVID-19 has been an issue. I think what has been most interesting to me about infectious diseases is its ability to adapt and evolve with existing threats and challenges that are here. So how do we deal with things like antimicrobial resistance in a way that we can, when it's becoming more resistant to antimicrobials that we have? How do we deal with new and emerging infections in this era of climate change? And then when I think about specific projects or initiatives I'm excited about, then I have a clear bias towards my division, because I think the team is doing some fantastic work in the area of infectious diseases. And I just can't wait to see what we can do, what more we can do. My work here is very mission driven. I feel like one of my goals is to really develop global health leaders in the global south, so to build capacity. So how do you take an established institution like ICDDRB and take the fantastic research that's already been done and help empower the junior scientists to become independent and to leverage the existing resources to do that? That is what I see as one of my challenges here today.
We're very thankful for that video, and I'm sure you'll agree that Dr. Prue-Ying will be greatly missed, and our thoughts and condolences go to her and her family and colleagues. We're forever grateful to the work that she did, and we thought it most important to take opportunity today to recognise her contribution as we, as a global child health team, continue her mission. I'll hand back over to Helen now.
Thank you so much, Becky. If I could please ask that someone could share my closing slides.
I think we can see them.
They're the opening ones.
Oh.
Okay. While we're bringing some slides up, I'd really like to say a big thank you, first of all, to all of you in the audience. It's been a very long, but hopefully an inspiring and very interesting day. And thank you for staying with us for all of the day. We've had some great discussions on the chat. Hopefully there has been a lot of food for thought and ideas, both about how to collaborate, new collaborations, new research, new advocacy projects. So thank you very much. I would like to say a really big thank you to MEDAL, particularly Ria, Alan and Sue, who have been supporting us with numerous tech trials and issues on the day. And so thank you very much. MEDAL is a fantastic platform. We've used it before for our events, and I would highly encourage other groups to also consider using it. I would like to thank the organising committee, especially Shruti, who has led us through organising this wonderful day, but also to everyone on the committee who's doing a fantastic job, always in good humour and with kindness and compassion, which is incredibly important in all aspects of life. So thank you very much. I would also like to thank the chairs of all the sessions, and importantly, all of the speakers who have done just given us such an interesting and diverse day. So thank you very much. Okay, so we'd appreciate feedback about the conference. The winter conference runs every year around this time, and we're always looking to tweak it, to think about themes, about ways that we can improve. So following the conference, you will receive an email which should have a link that you can go to and complete the feedback. Once you've done the feedback, you will be able to get your certificate of attendance. And this conference was awarded 6 CPD points from the Royal College of Paediatrics and Child Health. So some of the themes that have come out of today, we will be taking forwards on CHIFA Forum, which is the Child Healthcare Information for All. It's a discussion forum which is facilitated via email, and ICHG, along with ISOP, provides financial support to CHIFA, and we are partners. So we'd encourage all of you to join CHIFA if you can. It's a very useful discussion platform. And if you have any ideas for how things that you want to discuss coming out of the conference, then please let us know, and we can organise that via CHIFA. So we'd encourage you to join us in ICHG. I'm sure most of you are aware, but we're a speciality group of the Royal College of Paediatrics and Child Health. We have a lot of activities going on focused around advocacy, research and education. We also have a mentorship scheme, and we have 2 meetings a year, the winter and the spring meeting. So there's a QR code here to join us. Our joining rates are very, very reasonable. They are free registration for students and also for LMIC residents. And we have a very strong commitment to decolonising global child health, and all of our activities we try and do through that lens. We also have a podcast, The Global Health Lives, and a very useful electives toolkit to give some practical guidance about going on global child health electives. Next slide, please. So our next meeting is in Glasgow in March 2025. This is part of the RCPCH annual meeting, and the theme of our session will be around innovation to improve newborn and child health globally. Particularly important subject, as highlighted by Dr. Banerjee, and there's a lot of innovations that are going on. So we're going to be hearing from Professor Michelle Hayes and talking about innovation with a digital app to improve neonatal outcomes, the NeoTree app. And also Professor Ed Clark from MRC The Gambia will be talking about innovations in vaccine delivery. There'll be fantastic keynotes, and we'll also have abstracts, competitive submitted abstracts regarding global child health topics. Next slide.
I think that's all the slides.
Our final slide. Brilliant. So all that remains to say is thank you very much for all your contributions. Please reach out to us at the ICHG. You can find our email address and website online, and we're more than happy to be in touch. And thank you very much. Goodbye.